Afternoon, everyone. This is Walter Koroshetz here at NIH, and I'm the chair and director of the Mdcc, chair of the Mdcc and director of NINDS. I want to thank the Mdcc members participating in today's meeting. Some of them are here in Neuroscience Center of Bethesda, and those joining remotely. Also, want to welcome the other muscular dystrophy stakeholders participating via our webcast. Let's start our introductions with people in the room here. As I said, I'm Walter Koroshetz, chair of the Mdcc and director of NINDS.
Hi, I'm Glenn Knuckles. I'm program director at NINDS, and I'm designated federal official for the Mdcc.
Hi, I'm Lynn Jakeman, and I'm the director of the Division of Neuroscience.
Good afternoon. I'm Jim Kiley. I'm the director of the Division of Lung Diseases at the National Heart, Lung, and Blood Institute, one of the institutes represented on the Mdcc.
And this is Emily Carisi. I'm a health program specialist, and I help run these meetings and keep the Mdcc moving.
That's real important. Thank you, Emily. So to get things moving, want to call out the names of the Mdcc members, and we'll see if they're on the line.
First, quick update. I have an email here from Dr. Alex Trinich from MSCHD. He will be delayed to the meeting, but will hopefully join us later. Dr. was able to call in today. Also, a quick note, everyone has been muted on entry, so you probably can't speak right away. If you're on your computer, there should be a red microphone. If you push that, you will unmute. If you are a call-in user, *6 will unmute. Mr. Ryan Fisher from PPMD, are you here today?
Hi, can you hear me?
Captain Jean Flynn from CMS, are you on?
Good afternoon.
Dr. Lester from NIAMS, are you on?
NIAMS.
Dr. Jen Levy from Coalition to Cure Calcium, are you on?
Hi, yes, I'm online.
Mary Squire, Department of Defense, are you on?
This is Kristen Stevenson. I'm sorry to interrupt, but I'm having a very hard time hearing any of the NIH folks. I can hear everyone else on the call, but I can't hear the NIH voices very loudly. I'm not sure if anyone else is having the same challenge.
Yes. Thank
I'm
you,
having
Kristen.
the same problem. I can
Yep.
barely
Yeah,
hear
I'm having the same problem.
barely
Same.
hear anyone.
Can you hear me now?
Barely.
That's better.
That's better. Okay, so we got to talk right into the microphone.
Okay.
Yeah, it's still too soft.
Okay, so Mr. Dan Perez, I hear you. Dr. Catherine Riley from HRSA.
Here?
Okay, great. Dr. Teresa San Augustine from ACL. And I've noticed I skipped Dr. John Porter from Myotonic. I've heard Ms. Kristen Stevenson from the MDA. Do I see Ms.
Yes, I'm here. Thank you.
Great. Do I see Ms. Natalie Steep from CDC?
Yes, I'm here.
And Ms. Cheryl Williams from Social Security?
Yes, I'm here.
Excellent. Have I missed any members or member representatives?
I did not hear my name. Dan Perez calling.
Oh, sorry, Dan. I recognize your voice.
So I'm registered as present. Thank you.
Now, I want to thank Glenn Nichols, Emily Carippi, Tom Cheever, members of the committee who helped develop the agenda for today's meeting. It's a pretty busy agenda, and so we're going to move as quick as we can. Before we get to the presentation, Glenn would like to cover some policies regarding conduct of the meeting.
Thanks, Walter.
Is there any way we can get more volume? I'm sorry to ask, but...
Okay, so I'm going to be like right in the microphone. Is that better, Dan?
Yeah,
Right.
anyone else on the phone, but yeah, no, it's very faint, so I apologize. Thank you, yes, it is better.
Okay, we'll have our IT people hopefully increase the volume. In the meantime, I'm going to swallow the microphone here. And hope you can hear me. Okay, so this meeting is being conducted in compliance with the guidelines of the Federal Advisory Committee Act, which addresses transparency of the advice provided to federal agencies and the management of any potential conflict of interest for any of the committee members. So in the process of developing the committee's roster and preparing the nomination of non-federal members to join the committee, we've documented any significant financial interests and involvement in other organizations that could pose potential or perceived conflicts. And the conflicts of interest or potential conflicts among federal employees is managed within our agencies. So we've provided recusal lists and documented waivers when appropriate to all of the members who have other relevant interests. If we were to take specific actions or have specific discussions affecting any of those entities, members would be recused from the discussions and actions according to the listed conflicts. However, members may participate in matters of general applicability affecting the listed entities. So for today's meeting agenda, we do not have specific actions involving any of the organizations or financial interests of our members, and so we don't foresee the need for any recusals. This meeting is open to the public, and it's being webcast. We will post a summary of today's meeting and a list of the committee members participating on the Mdcc website, which is mdcc.nih.gov. We have also posted a federal register notice about this meeting and invited public comments. No one has responded to the request for the opportunity to address the committee, so we have not scheduled any public comment period during this meeting. So I'd like to remind everyone in the room to please use your microphones and speak distinctly into the microphones. And those of you on the webcast, make sure that you mute your line except when speaking to reduce the background noise. And everybody, please identify yourself when asking questions or making comments. So I wanted to make sure all the members know that we have already scheduled the next meeting, which will be a full-day meeting on June 8th, 2020, and it'll be here in the Neurosciences Center. There's already been some interest in developing a morning session on patient-reported outcome measures and an afternoon session on newborn screening. So please let me know if you're interested in helping to develop those topics or if you have suggestions for presenters. And now I'll turn it over to Walter, who will give a presentation on news from the NIH and recent scientific advances in muscular dystrophy research. Walter?
Okay. Okay, thanks very much, Glenn. And Dan, can you hear me on this microphone? Okay. Anybody on the phone, could they let me know if you can hear all right?
Yes, it's
Yes.
good.
Okay, great. Okay, so I'm going to, again, give a brief overview of where we are at NIH right now in terms of funding, muscular dystrophy funding, and then talk about some of the really amazing advances that have come out over the last couple of months. So on the first slide, you can see the changes in the NIH budget that occurred from 2015 on. Recall that between 2004 and 2015, the budget was pretty much flat. We have had increases every year since 2016. Currently, we are under a continuing resolution, so we don't know what our budget is. we are dealing with three potential budgets: the President's budget, which is a significant decrease, the House budget, which is a significant increase, and the Senate mark, which is a further increase. Since 2015, when the increases started, the budget has gone up about 30%. Some of the funds that came to the budget are for particular areas of science. So, for instance, about 22% of the increase went to dementia research, about 5% of it went to the Brain Initiative, another 5% went to the Healing Addiction Long-Term Initiative. But still, there has been substantial across-the-board increases at NIH since 2015. This next figure shows the total funding for all the muscular dystrophy research since 2000. And so you can see there's been substantial stepwise increases in the funding for muscular dystrophy research, to 6.75 times an increase from 2000 to now. And this is, I think, has really helped the field in terms of moving the research forward. I would say, though, that since the 2015 increase started in 2016, 17, and 18, we've only seen about a 5% increase in the total muscular dystrophy research. So we still need to kind of grow the field and make more use of the funds that have come into NIH for muscular dystrophy research. The next slide shows the major institutes that fund muscular dystrophy research, and also the areas of science where the research has gone. So you can see that the National Institute for Arthritis, Musculoskeletal Skin Disease is the major funder. Then NINDS, NHLBI, NICHD, and a variety of the other institutes contribute substantially as well. You can see that on the right side, the distribution among what we call research projects, which are investigator-initiated research, and that's usually what drives most of the budget. And as you can see, it's probably about 2/3 of the muscular dystrophy budget. So that's research that comes in from investigators into peer review, gets scored, and then gets funded. The best scores getting funded. There's a piece going to intramural, a piece going to the Wellstone centers, and then smaller pieces to SBIR and training. And then if you look here, you can see the different types of muscular dystrophy and where their funding is coming from, how much there is, and also what institutes funding the different types of muscular dystrophy. And again, NIAMS is clearly the lead for all of these. And you may notice that if you add up different types of muscular dystrophy, the total amount is higher than the sum total, and that's because there's a number of other research areas that cut across all the muscular dystrophies that are counted in that muscular dystrophy funding slide. Okay, now I'm going to go on to a couple of things that I thought were worth pointing out that are really important steps forward in muscular dystrophy research over the last couple of months. So the first one is a study that was funded by NHLBI, and this is looking at spironolactone, which is a generic, low-cost mineralocorticoid receptor antagonist. And it was studied against a newer mineralocorticoid receptor antagonist that's more costly and not available worldwide. 52 patients were enrolled. They're basically treated early on in the course of the disease, and the idea is to try and prevent cardiac dysfunction over time. And the more expensive drug was found in previous trial to be effective, and the outcome measures here are basically MRI, cardiac MRI, looking at cardiac strain. And the take-home point was that spironolactone in this group was found to be non-inferior to eplerenone, the more expensive drug, preserving heart function in DMD patients who are at risk of a dilated cardiomyopathy. So hopefully that this will add to the evidence for using mineralocorticoid receptor antagonists to prevent dilated cardiomyopathy in kids with Duchenne muscular dystrophy and allow wider access to this type of therapy. The next one is an interesting story of a novel steroid-like drug called vamorolone. So the idea is to try to get the benefits that corticosteroids have shown, but to decrease the negative side effects of corticosteroids. So in this study, they enrolled 48 patients at different doses of the new drug vamorolone. And of note, this drug, this drug was developed by a number of different government and private sources, including the NCATS Rare Disease Consortia and a small business grant from NINDS to the company that developed this drug. And what they found was that the drug looked like it was, they could actually get better effects than you could get with steroids alone, with lower side effects, except at the really high dose, which was the 6 milligram per kilogram per day dose. The efficacy, though, looks like it was quite substantial at the 2 milligram per kilogram per day dose, where they did not get a lot of steroid-related side effects. So this is, I think, a potential step forward in using the anti-inflammatory agents that come off of the steroid backbone but have less of the side effects on bone turnover, insulin resistance, and Cushingoid habitus, weight gain, and so forth. So that was encouraging. The next one is a little bit complicated, but it's related to facial scapulohumeral dystrophy, where the mutation leads to overexpression of a protein called DUX4, and that alters the effects of what's called histone acetyltransferases. So these are enzymes that put acetyl groups onto the histones, which are the DNA binding proteins, and two in particular called EP300 and CBT. When the histone proteins are acetylated, it leads to expression of DNA genes that are associated with these histone proteins. And that, in FSHD, leads to the global accumulation of acetylated histones. And what the breakthrough in this study is the generation of an inhibitor of this IP300, which is one of the main acetyltransferases. And by inhibiting that acetyltransferase, there's a major effect on almost all the abnormal proteins and messages that are abnormal in the DUX4 cellular models. So the slides show that this IP300 is powerfully, pretty much obliterates the abnormal acetylation that's caused by the DUX4 overexpression in these cell lines. So a potential major breakthrough if this is something that can move on through the pathway from cell culture to animals to people. The next one is interesting study going from mouse all the way to larger animals. The German short-haired pointer dog, lacking dystrophin, is the larger animal. The idea here is that by using the utrophin gene instead of the dystrophin gene, there may be some advantages in delivering high doses of the utrophin gene as compared to the dystrophin gene in kids with Duchenne muscular dystrophy. And the reason for that is that one potential problem with giving a new gene to people who had it deleted at birth is that the immune system may see this new gene as toxic. So in Duchenne muscular dystrophy, there could be, and there has been shown evidence of an immune reaction to new expression of dystrophin. Utrophin, however, is present normally, and so in the body there would not be immune reaction to utrophin. And here they show that by giving high dose of utrophin, there's less immunogenic reaction in the mouse, and significant improvement in muscle function and suppression of muscle degeneration. This was easy to show in the mouse. It gets trickier in the larger animals, and it's going to get trickier in people because the dose has to escalate to the point where it can handle the increase in muscle mass as the child ages. But they were able to go into a dog model, which is a larger animal, and show prevention of muscle pathology in the golden retriever dog using intravenous injection, and then show decreased immunogenicity by actually injecting right into the muscle of a German short-haired pointer and demonstrating that there was very little immune response as compared to what's been seen when you inject the dystrophin gene. So this came out of UPenn. So a potentially new twist to give us more effective gene therapy for Duchenne muscular dystrophy. And finally, there was the last one is a somewhat what could seem tangential, but another way of affecting the immune system is to actually take cells and genetically modify the white cells from, say, a bone marrow biopsy, and then inject them back into a person, or in this case, an animal model of muscular dystrophy. And this is used in this case to deliver modified cells that have increased expression of what's called leukemia inhibitory factor, which really cuts down on inflammation and damage in the muscle. So you may have heard of CAR T cells for cancer. This is kind of like a CAR T cell therapy for muscular dystrophy, because they also show that you could take the bone marrow cells and then put them into a mouse who has a muscular dystrophy by injecting them intravenously, and you see the same effect on reducing pathology. So another potential avenue towards therapies. So those are the advances that I wanted to highlight. And there are a couple of programs we wanted to let people know about coming up. So NIAMS is holding their Coalition for Creating Connections for Science, which is for fostering, facilitating information sharing between NIAMS and professional and voluntary organizations. You can see the link here. And then the NINDS will be holding its similar venue called the NINDS Nonprofit Forum in June, and the link is here. So the agenda for today going forward is, as seen here, we need to develop nominations and vote on MDC chair for 2020-2021. There are new member presentations, particularly Cheryl Williams from the Social Security Administration, meeting reports from many of the committee members, and then, as we always do, try and pick an MDCC action plan relevant topic. And today, we're going to be talking about patient-focused research. And then Emily, if we have time at the end, can give an analysis of the 2018 member organization funding data. So with that, I'd like to close and happy to answer any questions from folks on the phone. Any questions from folks on the phone? Okay, if not, I think I'll hand it over to Glenn.
Okay, so I'm trying out a different microphone. Can the people on the phone let me know if you can hear this better?
Yes.
Is that better than the previous? So it seems like we've got some problems.
I think it's worse.
It's worse?
Your volume is better than at the very beginning, but it's worse than the last presentation.
Okay. Yeah. All right. So that helps. Now we're figuring it out. So there seems to be some issues with the microphones here at the table. The podium mic is the best, and this handheld mic is kind of okay. All right. So we're going to change things up in the agenda a little bit and move on to the new member presentation. So so we'll have a presentation from Cheryl Williams. She's a new member for our committee representing the Social Security Administration. Cheryl is the director of the Office of Medical Policy and will present an update on the SSA Compassionate Allowance Initiative. Cheryl, I'll turn this over to you. Cheryl, you may be muted. Are you on? Okay. Cheryl will try and figure this out for you. Why don't we, while we're dealing with that technical issue, go ahead and move on to one of the meeting reports from member organizations. So at each of these meetings, we invite member organizations to tell us about conferences or workshops that they've conducted. Today we'll have 4 meeting reports from patient advocacy groups and 1 report from NIH. So to accommodate the scheduling of participants, we'll start with a meeting report from Kristen Stevenson of the Muscular Dystrophy Association, and the other reports are later in the agenda. So Kristen will tell us about the clinical and scientific conference that was held in April of this year. Kristen?
Great. Thank you so much. I appreciate it. And can you hear me okay?
Yep, very well.
Great. Thank you for the opportunity to share just a quick overview of the MDA 2019 Scientific and Clinical Conference that we hosted in Orlando, Florida this spring. And we do have a professional conference every year. In past years, we've alternated between a scientific conference and a clinical conference such that we have one every other year. And what we decided to do starting in 2019 was combine those to be a scientific and clinical conference. And we really did this in response to the reality that the clinical research and clinical care are becoming so intertwined and will become even more so with research that we really wanted to try to combine these two concepts into one conference. We also had a lot of participants who were interested in both tracks and who participated in both of the different types of conferences. And so we wanted in 2019 almost as a feasibility effort to put this together and kind of see what the impact was. And we were quite pleased with how it turned out, and we intend going forward to have a combined conference on an annual basis such that we don't have the focus just on clinical or just on scientific going forward. So in terms of the meeting itself, if you don't mind going to the next slide, please. And I know that many of you who are either on the phone or in the room were there or participated or both. And so thank you for all of you who were there. For those of you who weren't there, we would love for everyone who participates in Mdcc to join us at the conference this spring, if at all possible. It will be in Orlando again in March. And we have information about how to register and get involved on our website. But just briefly to give you an idea about the conference for those of you who weren't there, the 2019 conference, which was this spring, the keynote speaker was Dr. Janet Woodcock from the FDA, and then we had a panel group that immediately followed that that was headed up by Dr. Peter Marks from CBER and Dr. Janet Woodcock from FDA, along with a clinical expert and then an individual who's also former FDA and very involved in kind of patient-focused activities and the patient-focused drug development effort. And we had a little over 1,200 registrants, 130 speakers. We had over 300 abstracts, which we were really excited about. We were able to have a very robust abstract area at the convention. And we also had 22 CME credits that were available. And you can see the breakdown from the chart here on the type of participants and the type of registrants that were at the conference. And if you don't mind going to the next slide, I won't read through all of this, but the reason we included this information is because, as I said, this was the first time that we've gone with this approach where we combined the two types of conferences into one conference. And so we were very pleased that there was an overwhelming level of positive feedback in terms of how the conference went and then how the information was from an impact standpoint to the participants. If you don't mind going to the next slide, please. Just to give you kind of a sense of what some of the sessions looked like, the topics that you see on the left represent the titles of some of the scientific sessions, and on the right, some of the clinical sessions. And I think what we found really exciting and interesting was that we had a lot of people who may have traditionally followed the clinical track that opted to participate in scientific sessions and vice versa. And on our feedback form, what we heard loud and clear was that those who maybe would be more inclined to go to a scientific session, for those that did choose a clinical session, they found it to be very informative and got to appreciate a whole different aspect of an area that obviously impacts their work and vice versa. And then if you go to the final slide, this is something new that we also did in 2019 that we're really excited about. Some of the folks participating today and in the MDCC joined us in this effort. But for 2019, what we decided to do, since MDA is an umbrella organization, and there are many disease-specific organizations that support some of the same patients, same researchers, and same clinicians, we really wanted to open up a space at the conference to invite other advocacy organizations to participate in the conference itself. And so we set aside a specific area in the presentation space at the conference and invited other organizations such as the ones you see listed here to participate. And so the list you see here are the associations that were interested in joining us at the conference and set up their own tables and shared information about their organizations and the great work that they are each doing. And we are taking the same approach for the conference that will be held in March in Orlando, and actually already have that pavilion filled out. It filled up very quickly this year, and we had a lot more organizations that were interested in it now that it's year 2. And so that's something that we're really looking forward to continuing to expand as we go forward. I think one of the ways in which we feel we can add value to this space as an umbrella organization is to work even more closely and more cooperatively with disease-specific organizations, since obviously our missions overlap significantly. And we were really excited about this as being a really tangible step forward to being able to do that. So thank you to all of you who are on the phone, who participated in the pavilion, and look forward to seeing all of you hopefully this March in Orlando. And let me turn it back over to you, Glenn.
Thank you, Kristen. Really great meeting. I attended the meeting, and it was quite impressive, excellent science, and very well run. Walter, let me turn it over to you, and I think we'll go back to Cheryl Williams' presentation from the Social Security Administration.
So great. So Cheryl, can you hear us all right?
Hello, can you hear me?
Yep, sounds good. Yes. So
All
next
right,
on the
thank you.
agenda is Cheryl, a new member of our committee representing the Social Security Administration. She's the director of the Office of Medical Policy and will present an update on the Social Security Administration's Compassionate Allowance Initiative. Cheryl, go ahead.
Thank you. Good afternoon, everyone. Before I go through the 4 new CAL conditions that we announced this year, I just want to talk about a few other policy areas that we, in my division here, are responsible for. We are responsible for the listing of impairments for adults and children. They are used by adjudicators to process disability claims, Social Security disability claims across the enterprise. We're also responsible for childhood disability policy, for age 18 redetermination policy, for continuing disability review policy, diary policy, drug addiction and alcoholism policy, medical equivalence policy, and of course the Compassionate Allowance Initiative, and that's CAL for short. It is not necessarily policy, but is closely akin and tied to the listing of impairments. The compassion allowances are an option that adjudicators can use to quickly identify an impairment within the evidence that they're looking at when they're adjudicating a case, to give them the option to process that case very quickly using the information that's there and, of course, the list, which will show them that the disorder that the individual is alleging is actually available from the compassionate allowance list and requires or would benefit from a faster adjudication if possible. Of course, most of the compassionate allowance conditions are alleged by anyone in the public or other. Generally, those individuals have information about their condition and can bring it to us almost immediately when they file their application. However, some of them just get the diagnosis or the information about the condition the day that they tell us about it, and of course, it's upon our responsibilities to get the information from the doctors or from whomever has provided them specific information about their impairment. So this year, actually for the last 5 years, we've worked diligently to try and announce new CAL conditions as we learn about them. This year, there are 4, and they're on the list if you can see them on the slide. CDKL5 deficiency disorder, Pitt-Hopkins syndrome, primary peritoneal cancer, and Richter syndrome. There's far more details than I can tell you in this presentation. If anyone is interested, of course, you can go to socialsecurity.gov and actually see these available on the list along with the remaining 237 CAL conditions that are there. I'm going to stop here and take any questions that you may have. I can identify also that there are several CAL conditions that are closely associated with muscular dystrophy, and there are 5 of them that are also available on the compassionate allowance list on our website. I'll take any questions that you have.
Thanks, Cheryl. I guess some of the folks might be interested in the process for putting new things on the list. Could you talk a little bit about that?
Sure. Again, available from the socialsecurity.gov website is information, more details about the Compassionate Allowance Initiative, and a link to actually submit a specific name of an impairment or a condition that you believe that SSA should consider. And you can do all of it right from the website. So you click on the link where it says submit. There's a form behind it that'll prompt you to give us information that we can use to actually examine the condition and actually get medical doctors to look at it and research to find information about how it may or may not meet the definition of disability for Social Security. But you can submit, anyone can submit a CAL condition right from the website.
I'm just looking. I see congenital muscular dystrophy, spinal muscular atrophy, or congenital muscular dystrophy.
Well, I have 5 that I can point out very quickly for you. You mentioned congenital myotonic dystrophy, Fukuyama congenital muscular dystrophy, Merosin deficient congenital muscular dystrophy, Ulrich congenital muscular dystrophy, and Walker-Wahlberg syndrome. They're all associated with muscular dystrophy.
Okay, great.
Hi. Can you hear me?
Yes.
Hi, this is Ryan Fisher from Parent Project Muscular Dystrophy. I was just curious of how many submissions do you all normally get in a year's time, and what the process is, how long the process is for review and then decision making?
Well, I'll give you an example of the month of October. I am aware of so far over 120 submissions. through the mailbox that is available in that website that I just talked about. So they just come in from there, not just from there, but those that are submitted from there, we take them in, we respond to the submitter saying we will review the condition and get back to you. We strive to do that within 30 days, but as I said earlier, we have contractors, doctors who work with the agency or work here in the agency. They also adjudicate cases and do research for us about these conditions. And then after they do the research and submit it to us for our policy analysis, then we go back and send a response to the submitter saying whether or not the condition meets our requirement. Number one, first, does it meet the definition of disability? And number two, if it does, we'll tell the submitter that it will or will not be included in the list of CAL conditions.
Okay, thank you.
You're welcome.
Are there other questions for Cheryl?
I guess, yeah, Dan Pearson. Got a question. Is, Dr. Williams, Ms. Williams, are there any things that you can point out to us, areas with muscular dystrophy and the determination of disability that are unique to the dystrophies, that make it more difficult to say,
no.
I now have the disability. And in the slowly progressive condition, they're often taught to find that line between loss of ADL or loss of function. Do you have any insights to how we can improve the process?
Well, actually, I think we've had conversations with constituencies within the not Mdcc directly, but with other muscular dystrophy groups and organizations who have come to us to talk to us about the very same question you asked. And what we did when we talked to them was we walked them through the disability determination process and how it works. Number one, there's the application for disability benefits. Of course, the information that is provided to us when that application is filed, and then the medical information and evidence that's submitted to us. The process does not change at all. The normal process for disability claims does not change for compassionate allowance conditions. The only change or the only identifier, if you will, for our adjudicators is that this is a condition that we've identified here in the Office of Disability Policy as a compassionate allowance condition, and you to the adjudicator.
My question is not related to CAL, just
just in general.
General SSDI, in general, and then also the relationship between that and Medicare and Medicaid, that kind of thing.
Okay, well, there's no difference in the way the process is described online. You have to file an application. Of course, you bring documentation or send us documentation. It takes, if you have information or documentation with you, the applicant, of course, when you apply, that is helpful to us and could speed up the process of your decision actually being made on your claim. If you don't, then it takes us a while to go to your medical providers and get from them your information or details about your condition. I don't know what the agency's numbers are about the time it takes to process a case, but at this point, the latest information I have is it could take 120 days. That's 4 months. It doesn't take that long if the evidence is already right in our hands when you bring it in or when the applicant comes into the office.
Okay. But is there anything that we should recognize because these diseases that make it difficult to get through the process?
We've heard different stories from. We try to give the person applying as much information about the process as possible. Unfortunately, we have the availability of appointments in person as well as by telephone. So those that are taken by telephone, of course, take a little bit more time for mail and exchange back and forth. But as far as any tips to make it faster or better, I am describing for you the process the way it works for everyone. And I suggest that if you have a question that you either call, there's a phone number associated with the website where the CAL information sits on the socialsecurity.gov website. That number rings directly in my office, and I can give you more information about a specific situation that you're dealing with, because again, every application is different and most of the circumstances are different as well. If there's something I can point out for you or someone else at our 800 number, we will certainly do that.
And then one last question. Why is there a 2-year latency between the disability determination and the medical coverage? Why is that 2 years?
That is statutory, sir. We don't have any control over that. We have had several suggestions about waiting the 24 months for Medicare. Is that your question?
Yeah, what does that start? I mean, how was that ever decided?
Well, I don't have the date right in front of me. I apologize for that, but I can get it and share it with
just curious.
the Mdcc. But I don't know how long ago it started, but it started a long time ago, I can say that. When the program was started, there were several statutory rules that were put in place, and now we're still following those. And I believe that at the inception of the disability program, or shortly after, that was a rule set in place. We don't control that here. Again, we've had several suggestions about why it is, and is there anything that can be done to change it. And every time we ask the questions, we are told it's statutory, and it would take pretty much an act of Congress to change it.
Okay. Thank you. That's
You're
my
welcome.
question. Thank you.
Any other questions for Cheryl? Thanks very much, Cheryl.
You're welcome.
For each of our meetings, we choose a topic that relates to the action plan for muscular dystrophy. Try and develop some topics that address some of the obstacles and opportunities to advancing research leading to effective treatment for all the dystrophies, as well as access to care and services. The topic for today's meeting is patient-focused research, and I'll turn it over to Glenn to introduce this session, and thanks to everybody for participating in it.
Thanks, Walter. So I'm going to do a microphone check here to see how we're doing. So please tell me whether this is better. We'll call it microphone A. Test, 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 microphone A.
Yeah, this is much better. Your microphone.
Microphone B. How are we doing on microphone B?
Microphone B might be clear. Yeah,
okay.
B.
All right. So that's the table mics. Good. That's more convenient for us. Okay. So before I launch into the session on patient-focused research, I wanted to give one of our members an opportunity to talk about a funding opportunity announcement. So on the line is Teresa San Augustine from the Agency for Community Living. Teresa? We know there's a delay in her communication mechanism. Teresa, you may be muted, *6. Okay, we'll come back and get Teresa on that in a little while, or we can convey the information independently. All right, so as Walter said, we try to pick a topic for these meetings that has relevance to the action plan for the muscular dystrophies, and really try to address things that of interest to the group, and also interest to the areas of muscular dystrophy research and access to care and services. So this slide shows the continuum of research on diseases and conditions from all the way at the top, pathophysiology. So that's for kind of understanding causes down through developing and testing treatments to changing clinical practice. And patients or samples from patients, such as genetic samples or living cells, are involved in really all of these stages of research. So the NIH and other organizations recognize that patients are really experts on their own conditions, and patients are, of course, the target, the intended target for all the treatments that are developed. So it's really important that experiences, perspectives, needs, and priorities of the patients are meaningfully incorporated into all stages of the research. So this we'll refer to as the principles of patient-focused research, also called patient-centered research. So these concepts are part of the committee's action plan for the muscular dystrophies, including things like the need for patient-reported outcome measures and steps to decrease the burden of patient participation in trials. However, the terms patient-focused or patient-centered actually don't appear in the 2015 action plan, since that terminology and the attention to this topic has really been moving to the fore in the past few years. But MDC member organizations, we promote patient-focused research in different ways. So for example, for the NIH institutes, we support the development of patient-reported outcome measures. And one example of that is support for investigator Chad Heatwall, who's on the line, I think, with us today, and may be able to participate in the discussions. And we also incorporate patient perspectives in guiding research directions by including patients and patient advocates in our advisory councils. So we know that patient-focused research is really a big and important topic. And so what we'd like to do is include presentations on this theme in today's and in future MDCC meetings. So we wanted to consider what are the different MDCC organizations doing, and can we identify ways to further enhance the research programs through the principles of patient-focused research. So to kind of kick off this topic in today's meeting, and then we'll continue it in future meetings, but to kick off today, we really wanted to learn more about the leading role that the FDA plays in promoting and enhancing patient involvement in the drug development process. So we're fortunate to have Meghana Chalasani from the Center of Drug Evaluation Research to tell us more about the FDA's PFDD program. So Meghana, we'll just turn this over to you, and I think you have control, or...
I do.
Hi, all. Hopefully, folks can hear me.
Yep.
Okay, great. Thank you all again for reaching out and including us to speak about this effort. I always enjoy speaking about this really critical work that the agency embarks on. I've been privileged to be working on the patient-focused drug development portfolio within the Center for Drugs for over 4.5 years now, and it's truly involved. And it's an exciting time to be working in this space. So Emily, if you could go to the next slide, please. Thank you. My standard disclaimer slide that everything I'll be stating is my own opinion. Next slide. Just to help set the context, I wanted to briefly remind folks about FDA's approach to benefit risk assessment, which is really that, it's a qualitative approach that is grounded in quantification of various data elements, including benefits and risks, and really remembering that we do this at a population level at the time of a marketing approval. The benefit risk assessment that we do is dynamic, and of course it evolves over the product life cycle, and it takes into several factors into consideration, including statutory and regulatory standards, societal expectations, personal values, and perspectives. If you go to the next slide, Emily, what you'll see here is our benefit risk framework. Next slide, please. Thank you. And so what you'll see here is the benefit risk framework, and this is a framework that is included in our review documentation related to products that we review, and you'll see that the first 2 rows here are the analysis of condition and the current treatment options. And so this is really setting the clinical context or therapeutic context in which a decision is made. And then you have the third row, which is the benefit, and the fourth, which is the risk and risk management. And these are, of course, more tailored to specific products. And what we saw back in 2012, under the fifth authorization of the prescription drug user fee timeframe, was that we really identified a need to systematically be able to collect directly from individuals living with a condition on what matters most to them. So really that disease burden and getting insight into the treatment burden to inform the first two rows that you see here, the analysis of condition and current treatment options, or in other words, that clinical or therapeutic context. If you can go to the next slide, please. And so as you'll see, in that first wave of patient-focused drug development, we really wanted, as I mentioned, to get that systematic collection of patient input. And so that's when FDA started conducting disease-specific patient-focused drug development meetings to hear directly from individuals living with conditions and their loved ones and caretakers on what matters most to them. And these meetings really strengthened our understanding of the disease and treatment burden. There was a public stakeholder process to identify which disease areas we conducted the meetings for. And there was really a range from chronic conditions such as psoriasis and alopecia to more rare conditions, including, for example, Chagas disease. If you go to the next slide, there's several, of course, disease-specific key learnings from these meetings, but there was also more broader takeaways that we definitely garnered. And at the end of the day, some of the key questions that we asked and found very valuable insight on are, like, what kind of symptoms have the most significant impact on your daily life or your ability to do specific activities? What are your current management approaches? Where are the gaps? What are you using as far as non-medical therapies, and what benefit may you be seeing that you see value in taking some of those non-medical products, right? Because that can help you identify where that unmet need is. And what would a meaningful benefit be? So for example, we say, if not a cure, what would an ideal treatment help improve in your condition or in your daily life? And so once again, this really helps us better understand what matters most to patients and their loved ones. And for each meeting, we make everything publicly available. All of the meetings, while they were conducted in the Silver Spring, Maryland area, there was a robust webcast. And so we make the meeting materials and the recordings all publicly available. But we also issue what we call a Voice of the Patient report. It's a summary report of the meeting, really using in their own words to describe their condition directly from patients, how they describe their experiences and so forth. And so all of these reports are also publicly available. And while we say that FDA is one stakeholder, certainly as kind of a recipient of all of this patient experience data and patient input, we're by no means the only critical stakeholder in the development process here. So we always have encouraged researchers, healthcare providers, other patients, and of course developers and sponsors to attend the meetings, to use the Voice of the Patient reports as resources to really inform the drug development pipeline and any decision-making related to that. If you can go to the next slide, the meetings and our key takeaways from each of the meetings really reinforced that patients are experts in what it is like to live with their condition, and that their input can inform the therapeutic context, the benefits that are most meaningful, acceptability of risk and uncertainty, the value and burden of risk minimization efforts, and how a product's benefit-risk profile changes potentially in the light of new information. And so we saw that this is really important information to collect in a very timely manner. Earlier in the drug development process, the better. But at the same time, it's also important to, it's not just like a one-time effort. You have to keep engaging with stakeholders in the community to understand what matters to them as their perspectives, experiences, needs, and priorities may also evolve. If you can go to the next slide, please. As we continued to think about, well, what's next in patient-focused drug development, we wanted to move the needle even further and further integrate patient input into our development, medical product development decision-making processes. So move from that qualitative, rich anecdotal input that we were hearing at these meetings to more robust and representative patient input. And so that's what we were trying to, that's the vision we had as we started shaping the next phase of patient-focused drug development here at the agency. And so that brings us to kind of the current phase that we're in, which is the 6th authorization of the User Fee Act. And luckily, there's a lot of parallels between PDUFA 6 and, of course, as you know, the 21st Century Cures Act. If you can go to the next slide, please, Emily, you'll see that this is kind of what we were really looking to do in this next phase. And that's really build in the patient input starting in the translational phase. So really identifying and measuring outcomes and burdens that matter most to patients, which will help design better clinical studies, recruit potential patients, and help improve retention as well. And this will inform and, integrate the patient-reported outcomes and patient preference information into the benefit risk assessments that we within the agency do. And then there's also a huge role for patient input even after kind of FDA's purview or going into post-market setting as well, and helping to communicate better information to patients and healthcare providers so that they can really make informed decision-making. And so the key message to take away is really just starting early and often. And you'll see that there's just a downstream effect of ways that this input can really inform decision-making, both for FDA as well as other key medical product stakeholders. I'd like to spend the rest of my time kind of going into a little bit more detail about what we're currently doing. So you can go to the next slide, Emily. We're doing a lot to further enhance the incorporation of patient input. I'll start by talking a little bit about what we're doing to meet our PDUFA 6 and 21st Century Cures commitments, and then end the presentation with some other efforts that we're both doing within the Center for Drugs as well as more broadly within the agency. So you can go to the next slide. Thank you. So one thing that we have implemented is what we call a statement of patient experience in our review documentation. This was a requirement by the 21st Century Cures Act, both that we start making a brief public statement in our documentation, and then every 5 years at the intervals you'll see noted here on the slide, that we make public a report on how patient experience data has informed regulatory decision-making as part of applications. And so this is something that we've implemented and we are continuing to pilot and implement. And if you go to the next slide, you'll see what version 1.0 of that kind of statement of patient experience looks like. You'll see that we're trying to capture and better understand clinical outcome assessment data, qualitative studies, patient-focused drug development or similar stakeholder-type meeting summaries, observational studies, natural history studies, patient preference studies. The science of patient input is truly evolving. So I know for a fact this table will also evolve as that kind of science evolves as well, and we see an identified need. But this gives you insight into kind of what we're looking at now as far as patient experience data and the different types of patient input that can inform decision-making. If you go to the next slide, please. Another thing that we really identified a need for was, once again, going back to kind of going from, in a stepwise manner, from the anecdotal qualitative information that you hear during the patient-focused drug development type meetings or focus groups to more robust data collection, that can really inform development and decision-making. So thinking of fit-for-purpose tools to systematically capture in clinical trials or in clinical studies as evidence for regulatory decision-making. And so this is why we've embarked on a patient-focused drug development methodological guidance series. If you take a look at the next slide, this has been a lot of the work that we're currently doing. The slide provides very detailed updates, but just to provide you with an overview, the first guidance in this methodological series discusses sampling methods that can be used when planning to collect patient input. So it provides a general overview of the relationship between potential research questions and methods when deciding from whom to get input, including defining the target population and the development of a sampling strategy. So really getting at the who. And so for this, we've issued the draft guidance and we had a public comment period associated with that. And so now we're currently in the development of a final guidance document. One thing that I do want to note that the first guidance also included is a glossary. We heard from the community the need for a more standardized set of terminology that's, really nomenclature and terminologies related to this world, the science of patient input and patient-focused drug development. And so that is also publicly available as well as in this draft guidance. So we define terms such as patient-focused drug development, patient input, patient experience data, all of these terms, as well as more guidance-specific terms. And so that's hopefully a helpful resource for all, and it's continuing to evolve as well. The second guidance in the methodological guidance series really will discusses methods for eliciting information. Once you've gathered the who from guidance 1, 2 is kind of the how. So it discusses how to do qualitative research, quantitative research, mixed methods, you know, it does go into a few specifics, I think, of issues that we've seen, for example, as an agency, as some of these methods have been implemented in the past, and really sharing some of the best practices and so forth. And so for this guidance as well, we've already issued the draft guidance, and I believe the public docket is still open. The third guidance is going to focus on really selecting, developing, or modifying fit-for-purpose clinical outcome assessments. So, you know, in the second guidance, you're using the methods from the second guidance, you'll be able to identify a list of impacts that matter most to patients, right? But not everything that's identified as important by patients, caregivers, and clinicians can really demonstrate change in a specific treatment trial or is measurable, right? So how do you select what to measure in a development program to show clinical benefit? And how do you identify or develop a tool to assess those outcomes of importance to patients? Those are the topics that will be the focal point of the third guidance in this series that's currently still under development. And then the fourth and final piece of the methodological guidance series is, with the third one, now you have the tool. So now taking it kind of home, as we like to say. So really incorporating those tools, the clinical outcome assessments, into endpoints for regulatory decision making. And so this guidance will address methodologies, standards, and technologies that may be used to really collect, capture, store, or now analyze the clinical outcome assessment data. And so it'll go into methods to define meaningful change in a COA-based endpoint, interpretation of results, as well as format and content required for regulatory submissions, specifically COA data. So for each of these guidances, we had a public workshop to inform the development of the guidance document. We really wanted to engage with our stakeholder communities, including patients, to really understand what guidance would be helpful in this space. And so we've had 3 of the workshops already, and so the 4th one is actually next week. We're calling next week, as you'll see I have several like shout outs for upcoming workshops. They're all next week. So next week is Hell Week for the PFDD team here, as we're lovingly calling it. And so the workshop for the Guidance 4 is next Friday, December 6th. Registration is still open. In-person attendance and webcasts are options. So I definitely encourage you all to consider attending. And in addition to the first 4 get at that methodological guidance series that I mentioned, in addition to that, we had one more policy type of guidance. So that's what we have here as PFD Guidance 5. And the last row you have here is a public workshop that we work with the Clinical Trials Transformation Initiative City to put together. And it was really a workshop on hearing from patients on and other stakeholders on enhancing patient input in clinical trials. So it focused on finding out about clinical trials, participation, like in the planning and conduct, like the operationalization of clinical trials, as well as like post-trial communication and so forth. And so the public meeting was held in March of this year, and summary report is now publicly available for that, and we've included a link here. So as you can see, we're doing a lot as far as guidances and so forth go. And we're also, once we've completed the guidance series, we'll also take a look at some of our own internal processes and procedures, our maps and SOPs and so forth, to make any revisions as appropriate to help, work in what we're putting in guidance and so forth externally. With that, if you go to the next slide, Emily. In addition to all of that, we have a range of other patient-focused efforts as well. As I mentioned, under PDUFA 5, we had the 24 disease-specific patient-focused drug development meetings. We continue to see significant value in having these meetings. And so while it's not a commitment, we are still continuing to host the FDA-led patient-focused drug development meetings. Recently, to inform the agency's work related to the opioid epidemic, we had a FDA-led PFDD meeting on opioid use disorder and a subsequent one on chronic pain. this past year, and the reports from both of those meetings are publicly available. That being said, there are a lot of conditions out there, and FDA has limited resources, and we cannot have a PFDD meeting for every disease area. And so we really wanted to open the opportunity for external stakeholders to use our meeting process as a model to host their own patient-focused drug development meetings. If you could go to the next slide, Emily. So these meetings, which we call externally led patient-focused drug development meetings, are still provide an important opportunity to hear directly from patients, caregivers, their loved ones on similar topics, what really matters to them, and the impact of the disease on daily life and their experiences with current treatment options and so forth. While these meetings are not considered FDA-sponsored or FDA-endorsed, FDA is open to and has participated in each of the meetings conducted to date. This opportunity was announced in December 2015, and so in 2016 is when we first started to have some of these externally led PFDD program meetings. And the program has truly grown. I'm pretty sure we've had more externally led PFDD meetings to date than FDA-led PFDD meetings to date already. It's a very engaging effort. And we have a web page that has a lot more resources as far as how to assess whether the state of the science for a given disease area is if it's the right time to have an externally led PFDD meeting, kind of communicates the resources needed to host one of these meetings. There's multiple ways to collect patient input and multiple ways to engage with the agency. So an externally led PFDD meeting might not be the right opportunity for every group. And so we try to share and be transparent with as much information as possible so that each organization can really decide on their own if that's the right opportunity at the right time for the community. And we have a lot of other resources publicly available related to that effort. Many stakeholders who have decided to conduct an externally led PFDD meeting have also seen value in putting together summary reports very similar to how FDA captures our meeting summaries in the Voice of the Patient report. And it's really helpful to have these reports publicly available as a resource for FDA, but also for developers and researchers and so forth. And so recently, FDA has launched an external resources or information related to patient experience webpage, which has some of these externally authored, publicly available reports and resources. Emily, if you could go to the next slide, please, you'll see just kind of a quick snapshot of how that web page looks. And you'll just see that if stakeholders are interested in having their report posted after an externally led PFDD meeting, they can submit it to this kind of repository of sorts, and we link to that report. Next slide, please. One of the other efforts that I want to talk about that we're doing is a grant program, a pilot grant program. We just made 3 awards under this program in this past September, so it's very new. And it's really to support the development of publicly available standard core sets of clinical outcome assessments and their related endpoints for specific disease indications. The 3 awards that we made in September, you'll see the information here. One is for a core set for migraine, another one acute pain in infants and young children, primarily those 0 to 2 years of age, and the third one is physical function. And for physical function, we're hoping that they'll be able to do this work in several different disease areas so that we can get a range of functionality, moderate, mild, and severe. And so with this grant program, what we're really looking to do is really encourage a more collaborative, multi-stakeholder approach to the development, modification, and selection of clinical outcome assessments that incorporates input from patients and care partners, as well as other key stakeholders. The launch of this grant program really came from a lot of feedback that we were hearing from the patient community and others about some of the challenges they were seeing related to clinical outcome assessments in the drug development space. They're very costly, they're very proprietary. Just because it's called a patient-reported outcome doesn't necessarily mean it's patient-focused, for example. And so after hearing a lot of this feedback, that's kind of how we shaped this grant program. It is a pilot, so we're still learning, but what's expected is that at the end of each award, which can be for up to 5 years, it's expected that a standard core set be publicly available at no cost or nominal cost. similar to all of the other PFD efforts that we do, we really do want to engage with the public as these core sets are developed. So the first public meeting under this pilot grant program is actually also next week. It's on December 5th, and for that meeting as well, registration to attend in person or webcast is still open and available. In addition to the two programs, in the interest of time, I didn't necessarily go into some of the other efforts, but I do want to acknowledge that everything that I've spoken about, for the most part, have been efforts under the Center for Drugs. And most of our work, there's a lot of overlap with our Center for Biologics as well. But there are other centers here and other staff here who are also doing a lot of patient-focused work, including our Center for Devices that has a patient science and engagement program. Our Oncology Center of Excellence has a robust patient-focused drug development program as well. And in general, we're looking to really increase the patient focus in other FDA activities. So for example, we post a lot of scientific workshops, and so you'll start to see that a lot of these workshops are really setting the context for all of these discussions by kicking it off by hearing from patients first in these PSCD-style sessions to kick off the rest of the dialogue. So really just setting the context and keeping the patient and their perspectives, priorities, and needs in mind. And so with that, if I could have I think almost my last slide, I just want to close off by talking about what our vision really is for patient-focused drug development. And that's really the sustained incorporation of the patient's experience in drug development and decision-making and really making it standard practice. And all of the programs and efforts that I've talked about are speaking at this by, what we're trying to do is really ensure confidence and reliability and accuracy of the patient experience data. So really through a guidance series, right? So just ensuring that the quality is there. Reducing regulatory uncertainty for the sponsor. Once again, something we're doing through our guidance documents by making everything publicly available, and then promoting the rapid, consistent adoption. And this is really something that we're targeting with our grant program that I just mentioned for the standard core set. So with that, if you could go to the next slide, Emily, I just want to do one plug-in for one other meeting that we have announced for 2020, and that's an FDA-led patient-focused drug development meeting for stimulant use disorder. Registration has not yet opened for that, but we do have our web page and save the date, which will be updated as meeting materials become available. And we will be hosting that meeting in the Silver Spring area. And so with that, my final slide just has some hyperlinks that might be helpful for folks that have resources. Otherwise, I'll turn it back to you, Glenn.
Great, thanks so much. How about any questions from folks on the phone? Let me just throw one out. I guess if you could talk a little bit about how you think these new data and patient-reported outcomes will interface in the future at the FDA with the previous legacy assessments. So just to kind of simplify, there have been discussions I've been involved with where the message is the FDA is really interested in these new things, but you have to have the old legacy outcomes to get approval for a drug. And right now we're looking more at add-ons as opposed to replacements. So that's maybe a oversimplification, but how would you react to that kind of a comment?
So I'm not sure if I understand the context of the question completely, because at the end of the day, a lot of some of this new sources of evidence, as they're being, I'm using air quotes for this, for the word new, they're not really new, even when we're thinking of terms such as patient experience data or real-world evidence, for example, for that matter. While they're not necessarily new, we've had, patient-reported outcomes and so forth, and that's kind of data submitted to us for a long time now. And so it's not necessarily new, but I do think that there's an opportunity for some of the work that we're doing now to improve the quality, ensure they're more patient-focused, reduce some of that uncertainty, regulatory uncertainty or regulatory burden, I would certainly say, for both the developers, for patients, and so forth, as well as FDA. For example,
let me just, so I guess maybe it wasn't entirely clear, but if you're in a condition where drugs have been approved in the past based on particular outcome measures, will the FDA still want to see those legacy measures or could they be completely replaced by more new patient-centered outcomes?
Sure. Oh, I understand. I see. I think it's definitely a case-by-case basis. I don't think we can necessarily make a blanket statement. But for example, as I mentioned, we've identified 3 disease areas where there's core sets currently being developed under the pilot grant program. For example, migraines and so forth. FDA is working very closely with the grantees. It's a UG3, UH3. I know there's a lot of NIH folks on the call, so you might be more familiar with the grant mechanism than I am. But in general, there's a lot of close insight from FDA and oversight as well. And so our clinicians and so forth are working side by side to kind of provide guidance as the core sets are developed. And so while FDA can't require the core sets, of course, to be, or endorse and say these are the only things that we'll accept, certainly we will have made it clear that we think that they are good sets to include, and we would share that information and make it publicly available. And because we were involved in it, it would reduce the uncertainty for sponsors and so forth about whether FDA would accept something or not and so forth as well. Whether they would completely replace previous measures and so forth, I think it really just depends on each case-by-case study in the science and so forth.
Thanks very much. Any other questions?
This is Jen Levy from Coalition to Cure Calpain 3. I had a question about the timing of the externally led PFDDs. I know there's a lot of people or organizations interested in hosting them. I guess, first of all, if somebody requests one from the FDA, how long does it take until that meeting actually occurs? And second, at what point kind of in drug development is it a good time to have this? Is it when a clinical trial is starting? Is it as early as possible? So those are my 2 related questions.
Sure, no, those are great questions. I'll start with the latter and then work my way backwards. So early, it's never too early is what I like to say as far as collecting patient input to inform a drug development pipeline, because there's just so much room. So companies, when they're first starting development programs, they put these things together called target product profiles, for example, TPPs, and all sorts of other initial decision making, and all of that should be informed by patient input, right? So it's never too early. But that being said, is there still a value in having patient input informing the design of clinical trials and so forth? Of course. So maybe if it is a little bit later down the pipeline as well, it's still informative. I would say it's always informative to hear from the patient perspective, but oftentimes what we will dissuade folks from doing is, for example, requesting an externally led PFD meeting, for example, after an application has already been submitted to the agency, for example. By that time, it's a little bit, I would say, it'll help the future and hopefully the forthcoming drug development programs and so forth. But it's really better to do it as early and often as possible, I would say. And then as far as the timeline itself, if you take a look at our webpage, and honestly the easiest way to find it is to type in patient-focused drug development FDA into Google. We do have a webpage that lays out kind of the quarterly review system we have for letters of intent for the externally led patient-focused drug development meetings. We do typically recommend submitting a letter of intent approximately 1 year in advance of when you're planning to host the meeting. It does take a good amount of time to ensure that you have a successful meeting. And so there's definitely more details like that publicly available on our webpage. That answers your question.
Dan Perez.
Go ahead, Dan.
Just had a question. Are there any in your experience with working with slowly progressive diseases or disc disease, are there any areas that you think the community might focus on in terms of any outcome measures or any disease-specific kind of things that, just in your experience anecdotally, are there any low-hanging fruit or things that we might sort of look to initially to understand that, just out of curiosity?
Yeah, that's a really good question. I'm not a clinician in this space, so I can't really comment, I think, on specific disease areas. But I do think, I know I have some folks from, like I know Paul from MDA and so forth is planning to speak after me, and I think they might have a lot more insight on that. Certainly, but I can talk more generally about types of efforts. You know, in addition to things such as engaging with the agency here, whether it's through externally led patient-focused drug development meetings or other types of engagement efforts, especially I think in this space, it's really helpful to have natural history studies, you know, so the design and kind of collection of really good natural history data is really good. I know we've put out several guidance documents related to that in the past year or so as well. So those are always really good. And so something to take a look at, it might be a helpful resource.
Okay, thank you.
Okay, why don't we go on? Thank you so much. To continue this discussion, so we have Ryan Fisher, Paul Melmeyer, and John Porter as experience in this space. Ryan, do you want to start off with letting us?
Yeah, can everybody hear me okay?
Yep, sound good.
Wonderful. So thank you so much. I appreciate the opportunity. And Magana, that was a really great overview of the initiatives out of FDA around PFDD. You know, as an organization, we've tried to take advantage of as many opportunities as possible to engage with the FDA, as well as other stakeholders on really the most pressing issues our community is facing at any given time. And we really do applaud FDA for their forward thinking and promotion around PFDD. And since the launch out of the initiative out of FDA, we've been attempting to innovate some in the space, as well as, of course, monitor and learn from the activities of other communities as this has evolved. And really, as the externally led PFDD meeting framework began to develop, we started to think about, you know, holding our own Duchenne community meeting, given that a lot had changed since the time we wrote draft guidance on Duchenne. We had more trials, we had 2 approved therapies, and a lot of activity overall in our space. So we actually, Magana and Dr. Mullins were gracious enough to convene a call with us, my colleagues at PPMD, to talk about the PFDD meetings and what might be possible to convene the Duchenne community. And we had mentioned to FDA that we really liked the framework we were seeing with the other PFDD externally led meetings in terms of things like live polling, patient testimonials, and panel discussions. But that we felt, given where we were as a community in drug development and the issues we were facing, even in access and reimbursement now in a new landscape with approved therapies, we sort of wanted to broaden that target audience beyond just FDA and include additional federal partners and agencies that touch Duchenne to highlight the patient voice across the trajectory of the disease and sort of reflect on where we were. And this was in 2018 when we held this meeting, and discuss these relevant issues around things like care and research and trials, and in the end come out with a report with some action items for our community. And with that, we would invite federal partners, many of whom are on the call today, to the table, but the onus for organizing all this would be on PPMD. So with that, we did organize a meeting in 2018 entitled the Duchenne Patient Focused Compass Meeting. And you can go to the next slide, Emily. So here's just a look at the meeting goals that we set out, really to identify current policy, care, and clinical trial priorities for our community, and look at this by subpopulation, because there's certainly differences within those subpopulations, as is the case with many diseases. Next, of course, to build on the existing relationships within our ecosystem, we view ourselves as conveners, and this provided us with that good opportunity to bring everyone together. And then finally, look at the gaps and specifically measures of impact not currently captured in these health economic models and value frameworks, something we were seeing in the access space in particular. So you can go to the next slide. Importantly, we didn't do this alone. We reached out to our partners in the space, and we put together a community advisory board to oversee the organization of and the preparation of the meeting, including the agenda. And many community members spoke on these panels and participated and attended for interaction in the audience, discussion, and the polling. And we also put together a white paper to sort of set the stage of, you know, where we've been, where we are, and where we see ourselves as needing to go. So you can move on to the next slide. And the audience, as I mentioned, was a broad swath of stakeholders, you know, within our, as we like to frame it, our ecosystem, our drug development ecosystem, which included Duchenne families and members of industry, our clinical community, and then, of course, on the right, you see the federal partners that were represented. And in total, in person, was around 400 people, and we also had the chance to live stream that meeting for those who weren't able to attend in person. And they were also had the ability to participate in discussion and ask questions and the like. And then, of course, it was recorded. So you can move on to the next. In terms of the meeting structure, as I said before, we followed a lot of the elements that we were seeing in the other PFDD meetings. And, you know, I think one of the things that I recommend to folks who are going to do something a little different like we did, you know, we honestly didn't have the time to submit the externally led application. And then, of course, we thought the scope of our meeting was a bit different. But the letter of intent and the materials on the FDA website, those are great resources that I think every community should look at the questions and the topics that FDA discusses within the application, and even go through the exercise of filling it out themselves, because it can inform a meeting like this if you're choosing to put it on yourself. So as we took some of those specific elements, we looked across and did the Duchenne journey across 4 specific panels, from the younger patients recently diagnosed through the more transitional phase, and then in the non-ambulatory phase. And then we also did a look back, and here you see the panel on the slide of 3 parents who, including our founder, Pat Furlong, who lost children to Duchenne, who were provided the opportunity to really reflect on those experiences, those lived experiences, and provide some insight to inform all the discussion. And then we had Q&A and discussion between every panel. And the element I loved is we did some live polling data collection to inform all the discussions happening. Meeting was recorded, live streamed, as I said, and then, of course, posted on our website. And I think you can go to the next slide. And the live polling aspect was really something unique. It was the first time we utilized this tool to gather some real-time data. We polled on things similar to what Meghana was talking about in terms of symptoms impacting daily life, as well as priorities for new treatments, including, you know, if a new treatment was available, what sort of things patients wanted to maintain in terms of activities of daily living, and even these global health measures. Cardiac, pulmonary, and the like. And then we polled on impact of disease on out-of-pocket costs for families. On the right, you just see an example of the results of the 3 cohorts of patient panels. And this question focused on which ABLs patients and caregivers hoped a new treatment could preserve or maintain. And we compiled these results and have posted them on our website. I think another thing worth highlighting here is that this data has been useful to inform future efforts around data collection. It also introduced this great new tool for meetings of live polling, and really since the Compass meeting, we've instituted polling at all of our annual PPMD conferences, polling not only patients, but others in the ecosystem, including clinicians and drug companies, and it's anonymous polling, so they don't have to fear that anyone's going to know their answers, and we've gotten some really interesting data that has come out of these meetings, and it gives a more interactive sort of you know, mechanism within meetings, so it's not just people talking at you with presentations. And then the final slide here, I just want to point out some of the specific outputs. Hopefully, we do believe we've expanded on the PFDD workshop framework by creating a bit of a different model based on where we were and based on who we wanted to target. We did collaborate with the FDA early on but this was considered separate from the FDA-led, externally led process and as well as the regular PFDD meetings. But McGanna and her team were wonderful in those early days to talk through what would make sense, and many of the FDA attended. We provided them with a Compass meeting report, and this report certainly has a shelf life, but I have to say it's provided so much strategic direction for this past year in 2019 and really beyond. And these are just two examples. The fact that there's caregiver and family spillover that's currently not captured in health economic models, it's informing some of the work we're doing in those areas. And then looking at priorities for data collection and development of new outcome measures that are most meaningful to patients. So with that, I'm happy to take questions. I hope this was a, albeit brief overview of something we have done within what we believe to be the PFDD intent. And we understand the FDA has limited time and resources, but we believe many patient groups are interested in conducting meetings and should look at what their priorities are, tailor the meeting accordingly. And we've talked to several groups interested in doing things of this nature, and we've provided some guidance around that. So thank you.
Thanks very much. Paul Millmeyer from MDA. You available to give us an update on MDA's work in this space? Paul, are you on mute?
Can you hear me now?
Yep, sounds good.
Okay, perfect. I was indeed on mute. So hello, everybody. This is Paul Mellmeyer at the Muscular Dystrophy Association. I'll start with an apology for background noise as I'm sitting at my gate at Union Station waiting for a train. So apologies in advance for that. Hopefully it's not too much of an impediment. But I'm really thankful for the opportunity to speak on today's call. I'm really pleased to be joined with really some of the veterans of patient-focused drug development and on muscular dystrophy patient advocacy more generally. So pleased to be following Ryan and Meghana. And I just wanted to speak a little bit today about the Muscular Dystrophy Association's involvement in patient-focused drug development, as well as actually an upcoming meeting that we're planning within Pompe disease. So first I'll just start by saying that MDA is evolving and expanding its regulatory activity in encouraging and advancing patient-focused research within neuromuscular diseases. And this takes on a variety of different aspects. We are participating or want to participate in many of the programs, initiatives, and opportunities that Meghana reviewed within her slides, including the development of clinical outcome assessments, including other programs that focus on surrogate endpoint validation and biomarker development, as well as other innovative drug development tools, all of which FDA is really being the leader on right now, as well as a discussion on the future of patient-focused drug development, whether under the current authorizing language and the future of patient-focused drug development within the next couple of years under PDUFA 6, or even the continuation of patient-focused drug development under the next prescription drug user fee authorization, the 7th of that kind, which will be happening in 2022. So we're really pleased to be participating in as many of these opportunities as possible because the data that can be collected, submitted, used, taken advantage of within all of these different programs can be incredibly impactful for the muscular dystrophy community, really the entirety of the neuromuscular community. And I think the work that PPMD has been doing with many of these programs, in fact, even programs that they have launched that aren't on the list that Meghana had been talking about, is really a perfect example of the ways in which the broader muscular dystrophy community could be going in and should be going in. So on to disease-specific, externally led patient-focused drug development meetings. MDA has not led our own as of yet. We have partnered on several. For example, we partnered with the Hereditary Neuropathy Foundation on an externally led PFDD meeting on Charcot-Marie-Tooth. We partnered with the ataxia community primarily led by the Friedreich Ataxia Research Alliance on a PFDD meeting on FA. Similarly, with Cure SMA and other organizations on spinal muscular atrophy. And then on mitochondrial diseases, partnering with the United Mitochondrial Disease Foundation and others on a PFDD meeting in mitochondrial disease. We're also partnering with the Fascioscapulohumeral Dystrophy Association or Society, I should say, on an upcoming patient-focused drug development meeting in April of 2020. So we're excited to be partnering with them on that. But primarily, I want to talk about the one that we are currently planning, and this is for March 9th in the Washington, D.C. area at the College Park Marriott, and it is for Pompe disease. Now, Pompe is actually not a muscular dystrophy. It falls within our umbrella. As you all probably know, the Muscular Dystrophy Association focuses on all neuromuscular diseases, not just muscular dystrophies. And Pompe disease is actually a metabolic condition. Just a bit of a background on Pompe. It's a glycogen storage disorder, which results in the deficiency of a certain enzyme called acid alpha glucosidase, which helps break down complex sugars, and without that enzyme, those sugars are not broken down, which results in a variety of symptoms, but most notably muscle weakening, particularly cardiac muscle weakening, pulmonary muscle weakening, and other musculoskeletal issues that can arise from Pompe disease. So there are two different types of Pompe disease generally recognized: infantile/early onset, and then late onset Pompe disease. And we're hoping for really an expansive discussion on all aspects of Pompe within this March 9th meeting. You've already heard from Ryan as well as Megha on generally what the focus of these meetings are. Ours is going to be a bit more of a traditional FDA externally led patient-focused drug development meeting. We're not probably going to be quite as expansive as PPMD was with the Duchenne Compass meeting that they held last year. And we're primarily, the audience will be FDA regulators, those within the review divisions that will likely be reviewing therapies for Pompe disease. So within this case, it would be the Division of Gastroenterology and Inborn Errors Products within CDER, which I do believe is either about to be renamed or already is renamed within the CDER Office of New Drugs reorganization, but I'm still learning the new names, so I'll just give it the old name for now. And then over in the Center for Biologics, the Office of Advanced Therapeutics, Tissue and Advanced Therapeutics, I should say. So we're going to be talking about some of the most burdensome symptoms for individuals living with Pompe disease, the variety of different viewpoints individuals with Pompe, as well as their caregivers and family members, bring to the experience in living with Pompe. It's actually, there's a variety of different severities, and really the severity can largely depend on just how much of the enzyme GAA is present. If there is little to no enzyme present, then the severity of the disease is much higher. If there are some enzyme present, then the disease is comparatively less severe. And this, of course, will result in different viewpoints on treatment options, on participating in clinical trials, on which endpoints are important, and the list goes on. Additionally, we'll be talking about clinical trials within Pompe disease. There are several ongoing clinical trials. There have already been completed clinical trials. There is one therapy on the market right now. It's an enzyme replacement therapy. It's been around for a little while now, and as the name suggests, it helps replace the enzyme that the individual is lacking within Pompe disease. However, there are two new treatments that are currently within phase 3 that could be if all goes well for the respective treatment, approved by FDA in the next handful of years, which again highlights how the discussion and viewpoints as well as data collected through our patient-focused drug development meeting will be important in informing FDA on the patient experience with Pompe as they review these upcoming products. There are also gene therapies a little bit further back in the pipeline. There are 3 companies as of now that are actively developing gene therapies, one of which is already actually being tested in humans within phase 1. And so we hope that these clinical trials will also be informed by the discussion within our patient-focused drug development meeting, as well as the ensuing Voice of the Patient reports. This was mentioned by Megan earlier. We are going to be creating a Voice of the Patient report so that there can be a lasting impact of the meeting, a lasting record of the meeting, and the data that will be collected during the meeting through live polling in the audience as well as webcast polling. And so we're hopeful that the Voice of the Patient report will be impactful both to FDA as well as to drug developers either in the room or online or reading the report later as they make decisions based upon the viewpoints expressed and the data collected in those meetings. We already know that this data is impactful. We've heard several instances in which data and viewpoints collected from these meetings and in the Voice of the Patient reports helped guide sponsors in the structure of their clinical trials, as well as FDA in the review of their products. Megan posted a slide on the statement of use of patient experience data that is now included within the analysis that FDA puts forward upon a new drug approval. Several times within that part of the FDA document, they cite information and data that was collected through the meeting or through the Voice of the Patient report that was impactful in the FDA review. So we do know that this data is used and it is impactful to FDA as it's reviewing products. Just a few more things for me, and then I'll be happy to turn it back. We will be talking about the future treatments and the viewpoints of the patient community, not only on the small molecules that are coming to market hopefully soon, but just the viewpoints on gene therapies, especially viewpoints of individuals in gene therapy of the disease is being well managed by current treatment options, something that's a very complex and very current topic in a variety of diseases, but will be of issue within Pompe specifically. One final note, we'll also be talking about diagnosis of disease. There's various different experiences in the patient community on diagnosing Pompe disease. Pompe has been added to the recommended uniform screening panel by HRSA, the Secretary Advisory Committee on Heritable Disorders within HRSA. So Pompe disease is on the RUSP. It is now being implemented in 21 states, but that still means that, let's see here, 29 states and DC still have yet to implement Pompe disease on their newborn screening panel. And then there are many other individuals, either children or adults who were diagnosed following the progression of symptoms and that were not diagnosed via newborn screening. So it could be different experiences and viewpoints to highlight there. So I think I've gone on long enough on MDA's activity on this meeting, specifically on Pompe disease on March 9th, as well as some of the other activities that we're doing. Happy to turn it back over to Glenn and happy to answer any questions.
Okay, thanks very much. I think let's go on to John Porter from Myotonic, and then we'll open up the questions from the group. So, John, are you available?
Yeah, so you guys hear me?
Very good.
Good, good. So I guess I'm going to echo a number of themes here going last. I'd like to thank Walter and Glenn for the opportunity to speak about Myotonic, formerly MDF's, Myotonic Dystrophy Foundation's experience in the area. I think it's really important that we're sharing on this forum, as well as I think across diseases. With Paul's talk, I was scribbling down a note to myself that there's a lot of similar class therapies, the enzyme replacement therapies, ERTs, for multiple lysosomal storage disorders. And so we're talking similar diseases, similar therapeutic class. So I think it might be important to not just restrict ourselves to muscle diseases when other things can be learned across a disease class like that. So our strategy for Myotonic has really been to evaluate the entire therapeutic development pipeline from discovery stages through post-approval marketing, and I think most foundations are looking in that direction, that there can be gaps in opportunities really at any stage that of therapy development that you need to address. So today's topic, the patient and caregiver input on burden of disease and expectations for therapies is one of these critical gaps in the pipeline. And I think we've got an opportunity here with the PFDD approach to both learn from patients and benefit them. I like the way that Meghana described how they're looking to improve the development and quality of patient-reported measures that, you know, in many ways may have already existed. But I like the way that she's looking at that, and I think that's an important message for us. So we took advantage pretty quickly of the FDA opportunity, and we were the first to hold an externally led PFDD meeting. So I guess it's ironic that I'm going last when Ryan's is more recent and Paul's is still to come. So our meeting was held in September 2016, and it was in conjunction with our annual conference, and I think that was a very important feature because it helped us ensure that we had a large group of patient caregivers in DC to attend the meeting, as well as DM researcher. Sorry, I revert into our lingo. Myotonic dystrophy is DM. Researchers, clinicians, and industry representatives really optimized that. So, like has been said, we had this at a hotel near FDA's White Oak location to optimize FDA staff attendance. And in all, we had over 200 participants, either on site or via the live webcast. We used the electronic system that Ryan has mentioned to poll on site, and I completely agree. That's hugely important. I mean, to get the answers quickly and have the feedback to the audience on what the overall polling results were thrown up on the screen after each question. It's really important. So we did online polling for off-site participants, and we held the online polling open for 30 days just to give people time to adequately respond. So a key point to the polling is that we collected anonymized demographic data on the patient participants, and that really helped us interpret the polling data. In other words, analyzing the traits of the respondents versus their polling answers. So the type of demographics we collected was really pretty basic. But what type of myotonic dystrophy, type 1 or 2, patient's age at the time, geographic location, age of diagnosis, and years living with myotonic dystrophy. So there's as many as 5 different classes of DM1 based on age of onset and symptomatology. And so it's important to sort that out in analyzing the answers. In terms of the logistics in the meeting flow, a lot of people doing these meetings have utilized James Valentine with Hyman, Phelps, and McNamara. James had substantial prior experience with FDA. He was in the patient representative program. I think I'm stating that correctly. And he actually helped launch this whole process, this PFDD program. And so we used them for planning as well as moderating our session. And I think he's done just about every externally led PFDD meeting since. So that was good to have that experience in leading it. So we had an overview by a leading clinician scientist expert, and then 2 panels, just 2 panels. We restricted to that. The first was living with myotonic dystrophy. We had 4 panelists representing different segments of the patient and caregiver community. And the questions were along the lines I think you've seen in Megan's slides. What are the symptoms with most significant impact on your life? How do they affect your life on a typical day, on your worst day? Are there specific activities that are important to you that you can no longer do or do as well? And how have your symptoms changed over time? So following the panelist presentations, we had an audience moderated discussion and polling on a set of living with questions that was really an expansion of those questions that I just rattled off. The second panel was geared toward assessing attitudes on currently available treatments and treatments in the pipeline. There's a lot of therapy development in various stages of the pipeline for myotonic dystrophy, but we currently do not have an approved targeted therapy. So this panelist was again representative of the patient population, patient caregiver population, and they talked about experience with the current strategies and interventions that are there for DM now. And as I said, that was nothing targeted. This is symptomatic management. The questions there were along the lines of what current treatments or therapies do you use for symptom management? How are these working? What are the downsides? Trying to get at side effects and how patients manage side effects. And I guess most importantly is what you want from an ideal treatment. And again, there was an audience moderated discussion and polling on these questions. And finally, an FDA representative, in this case, Jonathan Goldsmith, who's Associate Director, Rare Diseases at Cedar, gave immediate feedback to the audience. And I thought that was hugely valuable to have that. And I think really helped us going forward. I think when we had the conference calls to talk about this session and about what we wanted out of this session, what kind of gaps and everything, I think certainly a major reason is to help each other, gain experience and help each other, which the MDCC can do. I think Paul mentioned Cure SMA's patient-focused drug development, and we informed them quite a bit in getting ready for theirs. But also, what do we do with this data? How do we use it? So we prepared a voice of the patient report and completed and submitted that about 8 months after our meeting. And that was accompanied by our own patient benefit risk study that was developed separately. So trying to put burden of disease information into the context of benefit risk, which is, of course, how FDA utilizes it, was important, I think. So our report was a detailed analysis of patient input in the context of the demographic differences that I mentioned earlier. So we don't have time, nor do I think it's really valuable to talk about the specific outcomes of the meeting. I think we're all going to get different sorts of things, but you obtain ranking of potential treatment outcomes, information on the tolerability of different side effects, and information on the impact of risk-taking propensity of your patient population, or the severity of their symptoms and how that impacts their risk tolerance. And that, again, is going to be important information for the regulators, important information for pharma and biotech as they design and test candidate therapeutics, and the regulators assess risk-related benefit. So again, Megan mentioned that the FDA puts this feedback into their benefit risk framework, and again, we have a very complex multi-system disease, and we felt it was really important to try to capture that. And one big gap for myotonic dystrophy was in terms of the CNS consequences, and we didn't get that much of a handle on that with the PFDD. So essentially, we ran another PFDD at one of our annual meetings that focused on CNS symptomatology of myotonic dystrophy and really helped us gain insight into CNS symptoms that are a critically important part of the burden of the disease and what the patient's perceptions of what to measure and what types of therapies they want to see. We followed that up with a meeting that Molly's going to talk about later today that focusing on CNS endpoints. So that was more of a research/industry meeting, looking at potential endpoints for clinical trials, but taking into account this new patient input from a follow-up meeting. So, just one comment. I know we're going to get into some discussion that I've been to 2 of these externally led PFDDs, our own and the Cure SMA meeting, and looked at the output of others. And I think the key is how to best use the outcomes. And I think that's the piece that the sharing of experiences in outcomes of them across the members of this group would be really important. And just the final observation, I thought that what Megan had to say about and what we've seen from FDA's PFDD guidances look to be a great step in the direction of doing exactly that. How do we best utilize the data that's coming out of these meetings? Okay, that's all I have.
Thanks very much, Ryan, Paul, John, Megan. A lot of rich ideas out there. So I want to open it up for questions or discussion. Folks on the phone. People are thinking, let me try to think to the future, and so this maybe each of you on the phone may have different views on this, but for a new drug that's in a trial that's going to be hopefully looking for a label at the FDA at its conclusion, we usually, what we've seen is that there's a lot of discussion and wringing of hands about what the primary outcome should be. And certainly, as I mentioned before, there are oftentimes legacy measures that people use for the primary outcome. But the trial really kind of lives or dies based on whether it hits that primary outcome. So looking forward, as data for a trial expands out into multiple different spheres of the patient's life and what the effect is during the trial of, say, the drug, a couple of things could happen. You could potentially see everything kind of go in concert with each other. So you hit the primary outcome, and then all the patient-reported or patient-centered data is in line with that. And I could certainly see how that would really support approval at the FDA level. The question is, what happens when you see discordance? Could you see somebody misses on the primary outcome, but a lot of the patient-centered reports are clearly better, or probably what's more likely is the primary outcome hits, and then the patient-reported measures are a mix of things, some not moving, some moving one direction, moving the other direction. So how would the FDA handle that type of situation, just generically, and how are the organizations we talked about thinking of how their work will affect what they want to be the primary outcome going forward versus kind of ancillary measures that go with the final package? Two questions, one to Megan about what would the FDA be doing with discordant data from versus the primary versus these other secondaries?
Sure. So I think that's a really important question, and I hate to say the same thing again and again. So of course it's going to be a little bit case by case, of course. But I think I'll introduce a new idea here as well. A lot of the work that we're doing with the guidances and so forth right now is really getting us towards that, the clinical outcome assessment, the patient-reported outcomes, and so forth. But there's another type of patient experience data as well, right? And so this is patient preference information, PPI. And so a lot of the qualitative groundwork and the sampling of some of those like guidance 1, guidance 2 topics still apply, I think, to collecting patient preference information. But this is the type of patient experience data that might be useful in certain, in certain regulatory decisions. For example, as you mentioned, when patients' views about what's important to them related to benefits and risk really varies considerably within a population, or, for example, when patients' views might differ from those of healthcare professionals or clinicians. Or, I mean, another example would be like significant risks of the treatment exist relative to the expected benefit and given that therapeutic context and so forth. So there's definitely areas where additional types of patient experience data might be of particular value. And so that might, you know, help tease apart some of those differing viewpoints that you were getting at as well.
John, let me put you on the spot and ask, do you envision that the primary outcomes in the myotonic studies are going to change based on the type of work that you described in terms of the patient focus?
Boy, that's a good question, Walter. I don't know if I have any insight on that at this point. Most of the candidate therapies, and here's why, most of the candidate therapies that we've had to this point are in really early stage trials where I think the important thing is to get target engagement and modulation, that you know, with the mechanism of myotonic dystrophy, to get in there and you correct the splicing defect that's causing all the downstream stuff and see some early stage functional physiological sorts of things out of that. As a result, skeletal muscle is the target of early stage trials. When you got this multi-system disease that people have GI problems, CNS problems, all sorts of other issues, but we're really getting a very simple, straightforward readout. Do you correct splicing, because you can measure that doing a needle biopsy, muscle biopsy, and measure the change in splicing. And does it impact myotonia, which is an important symptom of myotonic dystrophy, but it's not something that the patients rank really highly in terms of having impact on their lives. We're pushing toward, you know, through that early stage stuff, trying to get to the later stage trials where we're going to need these kinds of measures. So it's not really clear what the registration measures are really going to be for myotonic dystrophy, because we haven't been in the late phase 2B, phase 3 trials that some of the other dystrophies like Duchenne have.
Well, how are you thinking about this in terms of Pompe? Are you envisioning that this is going to inform the primary outcome measure in future trials, or additional data that would either support or bring down an application to the FDA?
First of all, can you hear me again?
Yep, sounds good.
Okay, perfect. I think it doesn't have to be one or the other. I think it can be both. For example, the primary endpoint in most Pompe trials that have advanced far enough are, well, it's the 6-minute walk test, as is the case in many trials within muscular dystrophy and other neuromuscular diseases. I think, you know, those in the Pompe community, many are hoping that we will eventually get away from the 6-minute walk test. I think that's virtually everybody in the neuromuscular community. But as of now, there isn't a, you know, validated, qualified endpoints that can be a definitive alternative. So I think this meeting could be kind of one step in the direction of eventually replacing the 6-minute walk test as the primary endpoint in the majority of clinical trials. Well, what it can also be is the second thing that you said, which is informing additional endpoints, secondary endpoints, other endpoints that could be used either within individual trials or future platform trials for that matter. So I definitely think that we're hoping it can be both. I don't think we're under the illusion that this one meeting will change everything when it comes to 6-minute walk tests, and all of a sudden we'll have some validated perfect endpoint for everything going forward, but at the very least we're hoping that this meeting can contribute to the evolution of endpoints within Pompe so that eventually we can have a validated alternative primary endpoint to 6-minute walk test.
Yeah, and this is Ryan Fisher from PPMD, and we certainly have seen sort of a move away from the 6-minute walk test for various reasons, including just things we saw around incentivizing patients to give them $50 and they seem to perform better. but there are other issues associated with that test. And on top of that, from a patient-centered sort of approach, when we engaged the patients on that endpoint, we found that they didn't view it as meaningful to their daily lives. So the endpoint didn't fit into their sort of perspective of this matters to me. There's been a move more towards the North Star ambulatory assessment, things like getting off the ground, which they, in their terms, viewed to be much more meaningful than an endurance test. So I think that it's twofold. It's learning from the trials and natural history studies to date, as well as engaging the patients about how meaningful these outcomes are to them.
I suspect that the FDA has seen a composite of outcome measures that come in sometimes with a co-primary that might, something like the 6-minute walk test might relate to efficacy, and some other kind of functional scale might relate to where the person is in the disease course in terms of total effect on their life. Is that the kind of thing that you're looking forward to in the future? More of that, people said they like to get away from the 6-minute walk test, but the trick is how to get a measure that has got that kind of digital sense to it, where you can actually time it. And then when you get into measures of quality of life, that trickier. Does the FDA see many trials that come in with a quality of life outcome measure?
Either she's muted, or I know she has a flight coming up pretty soon. So. So I think we have Chad Heatwell still on the line, and Chad's an investigator that we've supported and has done a lot of great work in developing patient-reported outcome measures for neuromuscular diseases. Chad, do you have any comments on this? Muted. Star 6.
If I jump in while he tries to get on, Glenn, can you hear me?
Yes, go ahead.
Yeah, so Chad's proms really have a lot of promise for myotonic as well as other diseases that he's developed them. And I know they're being tried out in some trials as secondary measures with myotonic. And I think when we get to the stage of having a more definitive trial, I think all the work that Chad has done with being educated, with feedback from FDA and everything, is going to be really valuable for myotonic as well as FSHD and some of the other diseases he's developed these measures for.
Yeah, as I mentioned previously, I think there's some interest in maybe having the next year, the June meeting, have a morning session, kind of assess where we are on patient-reported outcome measures and how they fit into clinical trials. So,
yeah, and this is Ryan again, just to chime in if Chad isn't able to speak up. We're happy to be working with Chad as well as the MDA on a Duchenne-specific prom. So I certainly think that it would be wonderful to have something at the next meeting if Chad would be willing.
Okay, I appreciate your help, and we'll work together on making that happen. I'm sure we'll get Chad involved.
I'd also mention that Glenn runs a program for clinical trial readiness in disorders, and so it's a grant mechanism to fund projects that will get things ready for a clinical trial. Certainly, one of the most important being what are the best outcome measures to use in a clinical trial. So it is available if it's the right time. Do that.
good session. I think in the interest of time, maybe we'll kind of loop back and do the chair election. Here's the...
So, according to our charter, the chair of the MDCC committee serves as the principal advisor of the Secretary of Health and Human Services and the director of NIH. And the committee here assembled is to select a chair for a term not to exceed 2 years. And the chair of the committee is appointed by and then is directly responsible to the Secretary of HHS. So I have been my pleasure to serve with you over the last 2 years, but clearly my term is up, and so we do need to nominate and vote on a new chair of the MDCC that would start serving immediately after this meeting, go through 2020 and 2021. In the past, it's rotated between the IC directors at NINDS and NIAMS, NICHD, Child Health Development, and myself from NINDS. We'd like to invite nominations for the chair of the MDCC for 2020 and 21. As I mentioned, the chair is rotated among the IC directors, and in our rotation, the next person up would be Diana Bianchi, the Director of Child Health and Human Development, and she has expressed interest in being nominated as the next chair. She might be on the phone now.
I am on the line, yes.
Thank you.
Can you hear me?
Yes, yep, yeah, we can hear you.
Perfect. I can't see you, so it's it's blinded voting, but.
Dr. Bianchi, you're accepting the nomination?
I'm accepting the nomination.
Are there any other nominations for chair? Not hearing any, I'd like to ask Emily to go through the roll call of appointed members and ask for a vote or approval, disapproval, or abstention on the nomination of Dr. Bianchi as chair.
All right. Mr. Ryan Fisher, PPMD.
Yes.
Captain Jean Freund, CMS.
Approve.
Dr. Kiley. Dr. Corson. Dr. Jen Levy, C3.
Approved.
Dr. Mary Elena McGuire, DOD.
Approve.
Mr. Dan Perez, FSH Society. Dan, are you muted? I'll come back to you. Dr. John Porter, Myotonic.
Approve.
Dr. Catherine Riley, HRSA.
Abstain.
Dr. Teresa San Agustin, ACL. If you are still having problems connecting, I will contact you by email. Thank you. Ms. Natalie Sweet, CDC.
Approve.
And I believe Ms. Williams signed off. So, Mr. Dan Perez, are you still on? At the moment, I don't think we have any issues.
Thanks, Emily. I think we have a majority vote here, and hopefully we'll follow up with Dan and others afterwards. Thank you. I think Dr. Bianchi has been selected by the committee and will recommend her appointment by Secretary Alex Azar, and I certainly look forward to working with you, Dr. Bianchi, for the next few years as chair, and as I've enjoyed working with Walter on the committee.
Thank you so much, Glenn. It's really a privilege, and I look forward to working with everyone.
And I certainly second that it's been a really learning experience and a very fulfilling one to work with the folks on this committee.
Next, I think we'll go back to meeting reports. And Ryan Fisher from Parent Project talks about workshops that PPMD held, clinical outcomes for Duchenne muscular dystrophy, and developing plans for platform trial. Ryan?
Great, and I'm going to try to be cognizant of the time because, of course, I chose 2 meetings to present on, so apologies if I go quickly. But thank you, Glenn, and others, and thrilled to have Dr. Bianchi as incoming. So I'm going to focus my time today on these 2 topic-specific meetings we held in 2019. The first being the Duchenne Outcomes meeting we held in the spring. The impetus for this meeting really was to convene members across the drug development ecosystem and discuss outcome measures being collected in Duchenne and how each stakeholder group may view them differently from their own decision-making prism. What made this meeting unique for us was this is the first time we gathered such a group in one room where we included payers and HTAs as well. With an experience now with 2 approved therapies in Duchenne, we wanted to understand, really from their perspective, in particular, since they were making decisions based on these outcomes in Duchenne, and hear from others within the community. So you can go to slide 2, and here are the goals to provide just this basic overview. So what was happening in trials and research, to develop common understanding among the attendees of the outcomes being collected. This would include efforts aimed at enhancement and improvement of those measures as well. Identify the gaps in this data that are most relevant to the decision makers within the room, and discuss potential approaches to really facilitate collection of data that would help fill those specific gaps. And then finally, build consensus on where do we go from here and what do we prioritize. And I think it was important that we really did recognize the amount of activity within this area of research of outcomes development and the data collected to date, and then try to unsilo those efforts and promote a cross-learning and collaboration among the stakeholders in the room. So you can go to the next slide. Here's just a look at the attendees. Again, we had a nice cross-section of stakeholder groups represented, many of whom are on the line. And again, for the first time, we'd hear from payers and HTAs about their thoughts on these outcomes as they impact decision-making for access to therapies. And then you can move to the next slide. We did present some pre-meeting materials. We wanted to ensure that really everyone was coming into the meeting with a baseline understanding of the issues that we'd be discussing. So we provided an analysis of the outcome measures being collected in Duchenne trials and natural history studies. We painstakingly combed through clinicaltrials.gov and did counts on the measures being collected from these studies, the primary and secondary, and we, of course, provided the FDA Duchenne guidance, which was finalized in 2016. And then we also did a set of interviews with experts in Duchenne this is just a semi-structured qualitative interviews from clinicians, methodologists, researchers about the current state of research and data collection. Where were the gaps? Where were the issues? What do we see going forward? And we provided a summary. And then the agenda you see there on the right, it was a very full day. We started with the patient journey. We were able to repurpose the videos from our PFDD-like meeting, which is really one of the advantages to streaming and capturing that patient voice, is you could utilize those videos in other forums. We did a landscape review of the types of treatments, discussed the measures being collected, stages of Duchenne, and how they apply to all of these measures. And then we had a series of voting exercises, which was really interesting, and then followed by breakout sessions. And we recorded all of those breakout sessions individually so we could go back to the data. So slide 5, here's just a look at the voting exercise on outcome measures. Each stakeholder was presented with a set of colored dots, and we hung up charts, and you can move through these animations so all of them appear. Essentially, we gave everyone colored dots, each stakeholder group, and we asked them to go around to these posters and indicate which clinical outcome measures among the domains, really, we categorize them in domains, they believed most value to them as a decision maker. And we separated these into the 4 stages of Duchenne that we had the patient's videos on early in the meeting. What was important is we asked them to assume that the data was of high quality, because we even know that among some of these domains, we have gaps that we needed to work on, and that we would discuss later on in the meeting. And then they were able to use as many stickers as they wanted to, so they could put a certain amount of weight on some of the domains over the others. And then on the right, you see those specific domains that were included in the exercise. So you can go to the next slide. Here you see some of the high-level results. The box in the middle is just representing what the stakeholders were viewing in each stage. You know, we gave them some examples of the outcome measures with the domains, but we did say don't get hung up on those examples to sway their answers. We just wanted to provide them with those examples so they had a sense of what we were talking about. That when we were talking about endurance, would be something like the 6-minute walk test, but if we were talking about functional, we're talking about whether a patient is able to perform the task or not, rather than how fast they were performing it. So here you see some of these, just some of the data, but not all of it. We're producing a report. But the early ambulatory stage, of course, lower limb function received the majority of the votes, and it was higher than the endurance domains. The functional measures for lower limb were seen as more important. But I think the most interesting part of this early ambulatory stage was that the parents among our stakeholder groups really did view biomarkers, in this case, certainly MRI or dystrophin is very important, but the payers did not put any weight on those biomarkers. And that's something we're seeing certainly in the access space with among our first approvals with Teplirsen or Exondys. For its transitional stage, we had lower limb, had the majority of the stickers, but was followed by the upper limbs and functions. And payers view the upper limb as very meaningful in this transitional stage. And what's also noteworthy is clinicians viewed, separate from everybody else, that cardiac was extremely meaningful. Moving over to both the non-ambulatory stages, early and late, not surprisingly, we see upper limb received the large majority of the votes for what matters. And this is also here where we saw more of the PRO, quality of life care, given PROs as a very important thing to capture, and certainly a gap that exists within data collection in our community. And then as later on in the late ambulatory stage, cardiac and pulmonary, as patients begin to lose even more function, were highly prioritized along with those other PRO measures. And you can move on to the next stage. So finalization of the meeting report is going to happen in the next few weeks. It's taken a long time to piece through all the qualitative data that we got from this meeting. We received the transcripts from even the smaller brainstorming breakout groups as well as the full meeting. And we really wanted to look at capturing what the payers were saying versus the clinicians versus the patients. So it's been a long process, but we're getting ready to release this report. And just some of the work streams, and these are not inclusive of everything, included registry data collection, expanding on some of the stages of Duchenne, including early childhood and late non-ambulatory, which there was gaps in data. Other gaps included quality of life and patient-reported outcomes. There was this general agreement that we needed to engage the payer community much more intentionally. And then we've been working with an effort out of Hercules, out of Duchenne UK, our international partner, where they're creating a health economic model, and they're utilizing the critical path de-risk consortium we set up that's aimed at creating a disease progression model. So we found some additional areas of collaboration within Hercules, so we're not duplicating efforts. And then other areas of international collaboration on core data sets for the collection of data within the clinical setting and the post-market setting, and then in patient registries. It's really trying to align all these things in this new age of electronic health records and being able to pull data like we've never been able to pull before. How can we get it more consistency and really lay the groundwork work to have a more collaborative international effort, because as you all know, rare disease requires that. Okay, so with that, I want to move to the next meeting because I know we're running out of time, and go quickly over the Duchenne platform trial meeting, which we held in September. And I thought this was another meeting worth mentioning. It certainly was a milestone in our effort to explore even the potential of doing a platform study in Duchenne muscular dystrophy. This effort is really being led by my colleague, Abby Bronson. She deserves much of the credit for leading it at PPMD, and the idea around the platform trial really came from engagement with the FDA. Both Janet Woodcock and Billy Dunn are both big proponents of this, and just really also a general reaction to what we've seen in drug development for our community. We are living in the realities of drug failures, which is not shocking when you look at the statistics in drug development, but we felt that it was worth exploring the potential for doing something different. And that's how the effort around the platform study began well over a year ago. You can move to the next slide. You know, we have heard over and over again from our patient engagement work, simply put, that people just don't have enough time. We have to speed things up if we can for every type of patient, not just the small narrow cohorts that are being studied in some of these trials. We heard that the risk of assigning to placebo, and you can see some of the data here, is a deterrent from entering trials for some patients. We've heard that the inclusion criteria is way too limited. And this goes to a lot of other diseases, and many times because of age or functional status and the general heterogeneity of these populations, that people are just not eligible. And we heard that there's a worry of being in a trial could impact future eligibility. So over and over again, we're hearing these same things, and we're also hearing it's going to take a cocktail, a combination of drugs. So how do we address all these issues was the question. And is it worth trying to explore whether or not a platform study could be feasible? And could we potentially do something different and make the system faster and more efficient, more patient-centric at the end of the day, and then that path for combination therapies? So you can go to the next slide. And this is certainly not being done alone. We've had a collaborative approach, and we're building that collaboration in discussion with many of you on the phone today. And currently, we're working with the Critical Path Institute, who are the ones working on that disease progression model, and working with Berry consultants who have experience with platform studies. And IACT for Children, which is a network of pediatric hospitals focused on research. So next slide. And the hope here is essentially a value proposition. At the end of the day, for all those involved, patients having wider inclusion, minimizing placebo, essentially getting to a yes or no faster. We know patients that have been in drug trials for 5, 6, 7 years, and essentially this might be their one shot for a trial. And for drug companies, we hope we can save on efficiencies and trial costs. FDA, of course, improved data quality, something they've always advocated for, and they opened our meeting advocating for the exploration of these platform studies. And this is also really a way to focus drug development within the care continuum, that it will be part of the care center network and an option for patients after diagnosis, and then also impacting clinicians with that standardization, and patients obviously getting treatments quicker, which of course is the end goal. I'm not going to pretend that this is easy and it all looks very good on paper, but we felt that why wouldn't we at least explore the concept? So on the next slide, we held our first real public forum on this to essentially kick the tires, if you will, with all stakeholders who all have, different, they have different priorities, and even though we're all working towards the same goal, their own biases and their own needs and their own skepticism when it comes to this stuff. But this allowed an open forum, and we streamed the meeting to talk about the pros and cons of the platform trial, show a draft protocol that is not set in stone, but worth for discussion, and we had FDA speak on the need of this new way of drug development. We had panels, we talked about the assessments and schedules of the draft protocol, And then we even talked about potential for governance and all. Again, this is live stream recorded, and for those wanting to watch, we've broken it up into different chunks on our website. You can go to the next slide. In terms of timeline, we did a lot of the pre-planning, but there's much more work to be done in 2020. We have to do some fundraising around this because it's still falling to PPMD to fund the sort of infrastructure building of this. We've considered next year to be a planning phase, and a lot of work to be done in the collaborative network of stakeholders. So things that need to happen are still highlighted or in the works. And the reality is pharma companies will need to want to try something different and be involved. And certainly reluctance to change is often one of the biggest hurdles. And the next slide, this is really just a very basic look at where we hope to be for reality for patients and the patient experience and what it could look like to be enrolled in a platform study. Here you see patients are essentially assigned to 1 of 3 drugs, and this is just an example where 3 drugs were part of the trial. And then they're either receive active or placebo. Then it's a shared placebo over time. You'd either have a go or no-go decision, see if the patient is actually responding to treatment, and if not, they'd be washed out and randomized to another arm. So, important to note, we don't certainly envision these trials to include the foundational therapies aimed at replacing dystrophin. Rather, looking at the downstream therapies, which we're lucky enough to have a very full pipeline of good ideas about tackling those downstream impacts of the disease, but no real answers on what could actually truly impact the disease progression. We've had several failures and patients tied up in trials for many years. And, at the end of the day, this is only going to work if we have all stakeholders working in concert and on board. So 2020 is that still hard year to explore the feasibility and practicality of implementing such a concept. So with that, final slide is for the very difficult questions I asked that they be sent to my colleague, Abby Bronson, who is much more knowledgeable on this. And I'm happy to take questions at the end of the session.
Anybody have questions? Sorry about that. Well, yeah, I mean, certainly we're very intrigued by the platform trial concept. It needs to have a whole, kind of like a perfect storm of things coming together. A number of different agents to be tested, and people who own those agents or companies have to want to play in a collaborative network. But it could be instant. I know that the ALS groups are trying to pull this off now. See how that works.
Yeah, we're in close touch with them, and then other networks, iSpy and other platform concepts. There's many different ways to do these trials, basket and otherwise. But yeah, I think that the only way is shared learning, and we're trying to keep in touch with these networks to see how things are progressing on their end.
Can we turn to Molly White? Talk about the myotonic dystrophy CNS biomarkers workshop and research conference.
Molly, can't hear you, so *6, unmute, or microphone at the bottom on the WebEx.
Hello?
Yeah, I got you. Okay, good.
Oh, there we go. I hit *6 a bunch of times. I'm having technical disasters today, so my apologies. Hi, everybody. I really enjoyed Ryan's presentation. I wish I could see the slides, but I cannot load WebEx on this computer right now. Is there any way we're going to share these decks afterwards?
Yeah, so this whole meeting is recorded and will be available.
Great. Hi, Glenn. Okay, well, I really did try to put this overview together with an eye to staying within 10 minutes. So I'm going to go through this really quickly. It's really hard to distill 2 full-day workshops down to 10 minutes, and I'm probably going to do this a great disservice, but I will give it a shot here. So Myotonic, formerly the Myotonic Dystrophy Foundation, conducted an all-day CNS outcome measures development workshop on September 12th in Philadelphia, right before our annual meeting, to start the conversation around identifying endpoints and biomarkers for CNS targeting therapy trials, mostly because this area of drug development is lagging far behind skeletal muscle. And we've had a lot of outreach from industry asking us to please help move this along. We have therapies targeting the CNS that are being built right now, and we need to have biomarkers and endpoints that can be used in trials. So this is kind of a hurry up effort. So on the next slide, the first slide, the green slide, CNS Outcome Measures Development Workshop. So again, the objective was to identify current status of biomarkers and endpoints for CNS targeting therapeutic trials and define next steps to move forward. We had 135 members of industry, academia, and some venture firms in there, and it was at the Philadelphia Convention Center. Just a quick overview on the next slide, CNS and myotonic dystrophy. So DM1 prevalence based on the population-based prevalence study that we conducted using Hill spots is 1 in 2,300. It's extremely high, which means a lot of our folks are being misdiagnosed or not diagnosed until they have a congenital baby. The DM1 mutation is primarily based on RNA misprocessing in both muscle and the CNS. The structural changes in the CNS for DM, as far as we know to date, based on imaging, et cetera, are pretty modest. And this lack of degeneration and a real neuropathological, observation are making it difficult to identify targets. But some studies do show progressive decline, some studies don't. Observation from those of us here at the organization would indicate that there is progressive decline. And the CNS and muscle effects are bidirectional. So CNS manifestations in myotonic dystrophy can range from mild to severe, and it's usually based on the phenotype. Sleep dysregulation is pretty much true for everyone, as is excessive daytime sleepiness. Something like 90% of our people report that particular symptom. A lot of fatigue. There are definitely neuropsychological impairments, including cognitive impairment that gets progressively worse, and emotional and behavioral symptoms. A lot of our folks have significant apathy, avoidant personality, and brain fog, executive function issues. And then the congenital phenotype is particularly impaired from a CNS perspective. There are permanent developmental and intellectual delays, and a lot of our kids display on the autism spectrum. And as I said, they all include apathy and some personality differences. Moving to the next slide. It's going to be complicated to try to target CNS in trials because the disease is so variable from patient to patient, and there are variable symptoms like facial hypomimia and apathy, anosognosia, et cetera, avoidant personality, and impaired social interaction that's going to make it difficult to assess some of these things over time. And one of the things we think is that maybe coupling the study of drug effects with CNS disease study could accelerate overall development. It's going to require that we cast a pretty wide net. So we did have a robust discussion around potential CNS biomarkers and endpoints. We included some individuals from outside of the myotonic dystrophy world. And John Porter, who I believe is on the phone, was involved in framing this project up. And we did include someone from the NIH extracellular RNA working group, which was a very helpful thing. And she managed to provide some pretty important information around targeting extracellular RNA in the CSF that I think a lot of industry members are going to follow up on. We know the biomarkers improve success rates in trials from about 8.4% to 25.9%. And we know that there are some tool arrays, both through FDA and NIH, that can help measure CNS biomarkers. You know, obviously we want it to be non-invasive. That's pretty critical, feasible and stable and reliable, and treatment responsive. The possible biomarker approaches that we're discussing right now are molecular in terms of CSF, blood and urine, extracellular RNA and CSF in urine, and then CSF levels of T-tau, P-tau, and neurofilament light chain. All of those are being explored by a number of our industry partners, and then imaging. In terms of endpoints, we know that FDA has approved drugs for neurology in 2019. Most use performance measures as a primary endpoint. We were considering potential clinical endpoints such as sleep and daytime fatigue. Sleep, I think, is going to be a big potential endpoint for us because all of our folks, as you can see there, 91% have daytime sleepiness, and increased sleep requirement is over 50% of the population, which means that it'll have clinically meaningful benefit if we can target it with a CNS targeting therapy, and a lot of our patient population will report that symptom. And it's also going to be easier to measure than some of the other cognitive and behavioral pieces. Potential tools include the Epworth Sleepiness Scale, which is effective for burden but not so much for sleep. The Maintenance Wakefulness Test, which we believe is effective but of course requires a sleep unit, which increases costs. Accelerometry and actigraphy are effective, but they're going to require a longer collection duration for this population. But those are the biomarkers and endpoints that we're considering right now and that are going to require more follow-up. Moving to the next slide, in terms of considerations and next steps, we definitely need more longitudinal history data on sleep and basically on CNS in general. And some of the published documentation that we have to date is in conflict. We do believe that the assessment methods should be based on developmental age and functioning, not on chronological age. And sleep deprivation has a substantial impact on cognitive performance, so all of these things start to get bound up in each other, and teasing them out around therapeutic benefit is going to be tricky. And then the congenital myotonic dystrophy phenotype is going to have to be assessed separately through a separate track. It's a significantly different phenotype, and it has very different CNS symptoms. So we had a recent clinical trial assessing daytime sleepiness and fluctuations studying modafinil. The primary outcome was improvement in excessive daytime sleepiness using MWT, and secondary outcomes are listed there. And then in terms of next steps, the discussion really led to, of course, more working groups needing to address some clear methods for classification of different phenotypes so that we can really target who we're talking about, what CNS biomarkers can really work, what outcome measures are going to be most effective, effect size, and we're going to have to really figure out what that's going to be, and then establishing some data sharing. This is going to be essential since there just isn't enough of it. And then very quickly jumping to the next slide. That day was followed by a full day of our sort of what we call our research mini conference. It's the first day of our annual conference, and it's an all-day session just for professionals. We had 165 attendees from academia, industry, venture, and financial analysts for the first time, which was kind of interesting. The topics included DM biomarkers, what's working, and how they'll be used for drug development approval. Charles Thornton moderated that, and we had a great panel of speakers, including Frank Bennett from Ionis, folks from University of Florida and Iowa that have been working on muscle and CNS biomarkers, and folks from the rest of our clinical research network, Thurman Wheeler, who's been working on a urine biomarker, et cetera, looking at kind of more broadly what we have for the overall disease, not just CNS. We covered current therapeutic approaches, and for the first time, we had about 9 different therapeutic approaches being used to target the disease, including some newer ones around methylation and somatic expansion, which was exciting. We had 45 companies there this year, which was also pretty exciting since when I started this job in 2012, we had 1. So a lot more activity going on. We followed that with a state of the science for DM2, which is our sort of stepchild phenotype and one or genotype that needs a lot of attention, and we're trying to really drive more discovery around that particular genotype of the disease. We're hoping that the landscape paper that we have finished and which the SAC has reviewed will lead to some funding, hopefully partnership funding, to get some RFAs going to really drive more discovery around that disease. We anticipate that a lot of the biomarkers, endpoints, and potential therapies can target both DM1 and DM2, but it's important that we get more data in so that we can get industry interested in both. We had an overview on study and trial learnings to date, observations on design, endpoints, and patient enrichment strategies. This was led by our Scientific Advisory Committee member, Kathy Bishop, now with Locana Bio, formerly with Ionis. And we had a number of different presenters talking about studies that they've conducted, whether it's the study that Guillaume Bassez conducted in Paris, or Chad Hewell, University of Rochester, the Ionis trial, which was, of course, an industry-led trial, the PhenoDM1 study in London, and then the Optimistic study. So we pulled in as many different blinded studies as possible to look at what people were finding out about endpoints, what they were finding out about trial design, and what they were finding out as a result of all that around patient enrichment strategies that could be used for future trials. We also had a quick overview from someone from the Department of Defense on the PRMRP program, because myotonic dystrophy is now listed as a eligible disease. And our first year out in 2018, we brought down $3.2 million in additional research funding. We wanted to make sure that industry and academia understand how to use that application process and prevail. So we had someone come in and present on that. And we wrapped up with an overview on DM animal models, what we have, what we need, and why, and had a discussion around kind of, given the variety of therapeutic approaches and the number of companies coming, what else we need in terms of animal models. So that is an update. The objective with this whole professional track was really to understand where industry was in terms of therapeutic development for myotonic dystrophy and what we could bring to the table to help accelerate their efforts. And that led to the design of that professional track for the day. And that takes us to my last slide. And I think I stayed within 10 minutes there, or close.
Thank you so much. Any questions for Molly? I was just wondering, did anybody talk about animal models that could potentially provide clues to the pathophysiology in the CNS?
Yeah, so, you know, the only, we don't have good models for CNS. I think, and John can correct me here, I believe that Geneviève Gordon's DMSXL model in Paris does have some CNS phenotype. That mouse is really hard to get, and it's really tricky to work with. We've actually launched with Jackson Labs a human back transgenic mouse model effort, and it's currently available, although we don't consider it done. It's got 500 repeats, and it's not displaying phenotype, and we pretty much acknowledge that we have to get that mouse to 1,000 expansion count to get the CNS phenotype that we're looking for. But having had some robust discussions with Jax and Tom Cooper at Baylor and Geneviève in Paris, we're pretty convinced that Jax can do it, and they're aggressively pushing that mouse model to get it to 1,000 repeats, and then we'll see if we can get the phenotype. But that, to your question, is really a critical capacity issue for us. It's going to be really hard to test anything if we don't have an animal model to test it in, but we're hopeful about that back mouse. And that would be about the only mouse that we would have for CNS. We also don't have a good DM2 mouse yet, and people have been working on that for years. The expansions are so enormous that they have a really hard time getting them in. We have solid skeletal muscle mice, including Charles's HSALR. We have an interesting fluorescent mouse showing target engagement through Thurman Wheeler, which is a modification of the HSALR, and we've got a good cardiac mouse from Tom. So there's some good mouse models for specific, tasks, I guess you could say. But in terms of a really solid overall mouse model that shows really strong phenotype, both CNS and skeletal muscle, we're still struggling.
Thanks very much, Somali. Let's go on to our last presentation from Jennifer Levy, the Coalition to Cure 3, and talk about the 20th National Limb-Girdle Muscular Dystrophy Conference. Jennifer?
Hi, can you hear me?
Yeah, you sound fine.
Well, good afternoon, and thank you for the opportunity to speak about the National Limb-Girdle Muscular Dystrophy Conference. This conference was held over Labor Day weekend in Chicago. You could go to the next slide. The conference was a project of the Speak Foundation, which was founded by Catherine Bryant, and she was joined by two co-organizers, Carol Abraham, who's the founder of LGMD Awareness Day, as well as the Director of Community Outreach for Coalition to Cure Calpain 3, and Dr. Brad Williams, who's the Director of Research at Jake Foundation. There was a variety of groups represented, and also each of the co-organizers are individuals living with LGMD and with different subtypes. So there was some different experiences represented within the organization, within the organizers. Next slide. So a quick overview on LGMD. It's actually a diverse group of disorders with over 30 subtypes. These are categorized by causative gene as well as inheritance pattern. They all present with a similar weakness of the proximal muscles around the hips and shoulders. It's a progressive disease. And there is a lot of variability with severity, age of onset, and features. And some of the subtypes will have cardiac or pulmonary involvement. Even when you group all the subtypes together, LGMD is still rare with a prevalence of about 2 in every 100,000 individuals. So there were several goals to this conference. But the reason that I was really excited to talk about it today is that it was really the first of its kind as a conference for all LGMDs together, and especially one that's aimed at patients and their families. There have been patient conferences for specific subtypes, but it was never all of the subtypes, and also nothing nearly to this scale. So the goals of the organizers were to share information about the research and developments on the horizon for LGMDs, to really explain to the patient community and educate them on how their involvement can facilitate the development of treatments, but also to demonstrate to venture capitalists, biotech, other stakeholders that there's an LGMD community that's robust, it's mobilized, and it's ready to aggressively advocate for effective treatments. So several stakeholders were really united at this meeting. The majority of the attendees were patients and their families. Like I said, that included all subtypes, as well as patients that didn't have a genetic diagnosis yet. Either they had a clinical diagnosis but hadn't gotten genetic testing, or they might have had genetic testing but it wasn't conclusive. There were also researchers and clinicians that attended, and as well as industry representation. For the plenary sessions, a lot of these were focused on educating, especially the patients and their families, but also other stakeholders that might have been new to LGMDs. So there's an overview of the disease, but also talks about drug development, what that means and the patient's role in it, patient involvement in clinical trial readiness. And then there were talks about new treatment approaches, emergent treatments, and clinical trials that have either initiated or are on the horizon. There were two Ask the Expert panels where attendees were able to submit questions ahead of time and have the experts, in this case it was neurologists, physiotherapists, researchers, to answer their questions at the conference. And the keynote was presented by Pat Furlong, the founding president and CEO of Parent Project Muscular Dystrophy, who talked about advocacy that she had led in the Duchenne community and lessons that the LGMD community can learn from that. So the breakout sessions were, many of these were led actually by people with LGMD. Some of it was practical advice about living with LGMDs, and a lot of the sessions were aimed at certain subpopulations within LGMD. So there were sessions about pediatric LGMD, young adults living with LGMD, parenting as a person with LGMD. So this was a chance to kind of break out for sessions that might not have been applicable to the entire population. One of my favorite sessions that I attended was the participants' perspectives on clinical trials. So there were people that had participated in clinical trials that got up and shared their experiences. And I know a lot of people were interested to hear about that. The conference, the outcome was just really astounding. Over 400 attendees came from 16 countries. I think that this was more than any of the organizers were anticipating. And it was really fantastic to just see such a fantastic turnout. Like I said, there were patients and family members, there was industry representation, there was representation from many related advocacy organizations, and there were neurologists, physiotherapists, genetic counselors, other people that are involved with LGMD and learning about it. There are also 2 clinical studies that occurred at the conference. One was a genetic study that collected blood and saliva. The other was an outcome measures study where they had people do functional assessments with the intent of developing outcome measures that would be useful for clinical trials. So here's a photo of, I don't know, about 400 people. We all tried to squeeze in there. Some less quantitative feedback, though, was it was really just a landmark event. The first time getting so many of these people in a room together. People, you know, when you have a rare disease, you often have never met anybody else with this disease. So this was a chance to meet other people that are going through the same thing that you are. And I know that was really powerful for a lot of the attendees. Another really exciting thing was that they got to learn about this disease from the experts. There's especially a lot of participation from clinicians that are part of the GRASP LGMD study, which is a somewhat new natural history study led by Dr. Nick Johnson, but involving, I think right now, 11 clinics. So many of those neurologists and other associated researchers were there. So people were really learning about LGMDs from the people that know the most in the world. Like I said, I think there was just such great feedback that the plan is to have the next conference in 2021. But if you want to know more about this conference, there are videos of the talks that were posted online. So the website is there, and I also included the contact information for the co-organizers in case anybody wants to get in touch with them. So, thank you.
Thanks very much, Jennifer. Are there any questions from the folks on the line?
Jen, do you know where the meeting in 2021 is going to be?
I do not, but I could let you know, Glenn.
Yeah, yeah. When you guys decide that, you know, let me know and we'll publicize it through Mdcc.
Well, I want to thank everyone for their participation in the meeting. So as we mentioned, our next meeting will be in person. It's scheduled for June 8th here in Bethesda. Please let Glenn know if you're interested in helping to develop the agenda topic. The 2 we're thinking about are newborn screening and very related to what we talked about today, are patient-reported outcome measures. That's it from us. Is there any new business that people wanted to bring up before we close? Okay, if not, I want to close the meeting and wish everyone a very happy Thanksgiving and safe travels. And I thought that we really hit on some really important topics today that are going to, I think, be even more important as we move down the line towards developing new clinical trials in muscular dystrophy. Thanks very much.